Hi, good afternoon. Okay, so this is TND 3. So in this TND of surgery, we'll be discussing about thyroid, parathyroid, adrenal, Men's syndrome, then hernia, little bit about transplantation, oral cavity, salivary glands, urology. In that there is kidney, ureter, bladder, prostate, urethra, penile disorders, and testis. Okay, so all good. Should I start? How was the paper? Okay, if you have attempted the paper, just let me know how was it. Okay, so let's start with the first question. 35-year-old female, history of previous right thyroidectomy for a benign nodule, now undergoes completion for a suspicious thyroid mass. Several hours post-operatively, she develops progressive swelling under the incision, stridor, and difficulty breathing. Intubation was done and it was successful. Which of the following is the most appropriate next step? Okay, so this is a very important topic, that is complications of thyroid surgeries. Okay, complications of thyroid surgery. Whether you are doing surgery for a benign disorder or a malignant disorder, there are certain complications, and believe me, every year they are asking questions on this. Okay, so very important. The first complication we'll see. The first complication is bleeding. Okay, so bleeding after the thyroid surgery, whether you are doing a hemithyroidectomy or a total thyroidectomy, see, when you remove the thyroid from this part, there are chances that the bleeding from the superior thyroid artery branches or the inferior thyroid artery branches occurs. So when the bleeding will occur, the blood cannot go up, it cannot go down, it will collect in that area where the thyroid was there, and it will compress the trachea, and it will basically leads to airway obstruction. Okay, so bleeding after thyroid surgery will lead to airway obstruction. Patient will have typical complaints of, like in this question, there is dyspnea, there is stridor, there is difficulty in breathing. So what are you supposed to do? See, now the guidelines are a bit different, like if it is possible to do the intubation, okay, endotracheal tube intubation, if it is possible to go for that, if you have the facility, if you have the equipments to go for this, then you should do this. Otherwise, if this is not possible, if it is not available, then open the wound bedside. Okay, the moment you will open this surgical wound, because you have done the surgery in the morning, suppose, and in evening the patient is having this problem, the moment you will open this, the hematoma will come out, and the compression which it was causing on the airway, it will be relieved. Okay, so open the incision bedside. Okay, you don't have to take the patient to OT to open the incision. Incision you can open on the bedside, and after that shift the patient to OT and control the bleeding. Okay, the bleeding will not be that severe bleeding. Okay, it is just bleeding from the vessel, but the problem is the area is very, you can say, notorious, because if there is any hematoma, that will compress the airway. Okay, so bleeding will be managed like this. Okay, this bleeding is not enough to drop the hemoglobin or make the patient hypotensive. It is just, you can say, 60, 70, maybe 100 ml of blood, but that blood can kill the patient because of airway obstruction. Second complication we'll see after the thyroid surgery, dyspnea. Now, why the patient after thyroid surgery develops difficulty in breathing? One reason we have just seen, that is bleeding. Another reasons for this, like while doing surgery, sometimes there is laryngeal edema that can lead to airway difficulty or difficulty in breathing after the surgery. When there is very large swelling for a long duration, that large thyroid swelling will cause the weakness of the anterior wall of the trachea, and when you remove the thyroid swelling, that weak anterior wall of trachea will become free, and it will go and it will stick to the posterior wall, and that will close the airway. So weakness of the anterior wall of trachea is known as tracheomalacia. Tracheomalacia is also important cause. This is Faizan, this is just first question. Okay, so don't worry. This is the first question. We are discussing about the complications of thyroid surgery. tracheomalacia. Then nerve injury can also lead to dyspnea. We'll see how nerve injuries can lead to dyspnea. And hypocalcemia. Hypocalcemia can lead to tetany. In tetany, there is laryngospasm that will also lead to dyspnea. Okay, so these are the important causes which can lead to dyspnea. Now, one important question which is very frequently asked these days is, I'll just write like this. Suppose they write 40-year-old female after right hemithyroidectomy develops dyspnea in post-op period. Dyspnea in post-op period. What is least likely cause? What is the least likely cause? If I give you option A, B, C, D. So what is the least likely cause in this? A, B, C, D. These are the four options. So consider one new question in this. And believe me, this kind of questions are very common these days. 40-year-old female after right hemithyroidectomy develops dyspnea in the post-op period. What is the least likely cause? Okay, anybody, any guess? Any guess in this? Okay, the answer is hypocalcemia. Okay, hypocalcemia is the least likely cause. See, hypocalcemia occurs when all the four parathyroids are either removed or they go into ischemia. And when you are doing a hemithyroidectomy, even if you do mistake, you cannot remove all the four, because in hemithyroidectomy we stay on the one side. Suppose in this question you are doing a right hemithyroidectomy, so when you do surgery you stay on the right side, you don't go on the left side unnecessarily. So even if you do mistake, you can remove only two parathyroids, and even if one parathyroid is there patent, that will take care of the calcium levels. Okay, so hypocalcemia will occur when you do a total thyroidectomy, and during that surgery if you cause damage or removal of all the four parathyroids, then hypocalcemia can occur. Okay, so A is the correct answer. D, yes, bleeding can occur. Bleeding can occur in any case. Okay, Faizan and Subhasri, Roshni. Bleeding can occur in any case of thyroidectomy, whether you are doing total or hemi. So bleeding can occur in any case. Okay, so that's why A, that is hypocalcemia, is the answer. Okay, so dyspnea is another complication. Then last year this was asked, nerve injury. Two nerves which are important when you do the surgery for thyroid. One is external laryngeal nerve, which is very close to the superior pole of thyroid. And injury to this is more commonly injured. And injury to this will cause loss of pitch or tone of voice. Loss of pitch or tone of voice. Patient will not be able to speak or sing on high notes or high tones. Okay, so not a very major problem for common people, but yes, for professional singers and all, this could be a significant, you can say career-ending injury. Recurrent laryngeal nerve, on the other hand, this is important. If it is injured on one side, then it will cause hoarseness of voice. As it is hemithyroidectomy, this is what I am telling you, okay, Karunasiri, you will understand. Hoarseness of voice, bilateral recurrent laryngeal nerve injury will lead to both the vocal cords will come in the paramedian position, and it will lead to airway obstruction. Okay, so now this is your answer, okay, Karunasiri. Recurrent laryngeal nerve injury, if it occurs on both the sides, then it can lead to dyspnea. And in our question, the patient underwent hemithyroidectomy. So that's why I did not put nerve injury in the option also, because if nerve injury has to cause hypocalcemia, if nerve injury has to cause dyspnea, there should be both the sides of recurrent laryngeal nerve. And like I said, in hemithyroidectomy, you stay on the one side, you don't go to the other side. So you cannot cause a bilateral nerve injury during a hemithyroidectomy. Okay, is it clear, Karunasiri? Okay, so this is very important. Recurrent laryngeal nerve injury, whether it is injured on one side or both the side, it is significant. External laryngeal nerve injury is not that significant, but for yes, like I said, professional singers and all, this could be significant. Parathyroid insufficiency. Parathyroid insufficiency, like I said, it could be because of ischemia of all the four parathyroid or because of removal of all the four parathyroid. Of all four parathyroids. Okay, so even if one parathyroid is there, it will take care of the calcium levels. Okay, and parathyroid insufficiency will lead to hypocalcemia. And this hypocalcemia usually manifests after 2 days of surgery. So on the day of the surgery, on the next day, and mostly even after the next day, the patient does not have anything. The symptoms will develop after 2 days. Means from the third day or fourth day, the patient will have symptoms, because for the first 2 days, the calcium level which is already in the body, that will take care, and after that, when the calcium starts decreasing, the patient will have symptoms. Okay, so symptoms after hypocalcemia will not develop on the first day. Okay, suppose the same question, the patient after total thyroidectomy, patient develops dyspnea, and dyspnea on post-op day 1. Again they ask what is least likely. Least likely will be hypocalcemia only, because hypocalcemia, if it has to cause anything, it will cause after 2 days or 3 days, not on the day of the surgery, not on the next day of the surgery. And these manifestations are like there will be tingling and numbness around the lips, in the fingers. Tingling, numbness. There can be spasm in the hands or in the feet. That is carpopedal spasm. There can be tetany, which is very dangerous, because in tetany there is laryngospasm. Signs like when you tap in front of the ear, you will see twitching of the facial muscle. That is Vostek sign. Or when you put a BP cuff and you inflate it like 10 or 20 millimeter more than the systolic, that will cause spasm in the hands. So that is known as Trousseau sign. Okay, so these things you will see. Yes, very good, Pran. Vostek sign and Trousseau sign. Okay, so this is also a significant problem, hypocalcemia, if you damage all the four parathyroids. Okay, so that is parathyroid insufficiency. Next, this is also a question, thyroid storm or thyrotoxic crisis. Thyroid storm or thyrotoxic crisis is seen in those patients who are thyrotoxic, means hyperthyroid patient, and they are taken for surgery without preparation. Okay, unprepared patients. Unprepared patient means whenever you operating on a patient who is having thyrotoxicosis or hyperthyroidism, you have to make the thyroid level for a brief period close to the normal, because if the thyroid is secreting very high T3, T4 at the time of surgery, when you manipulate the gland will release very high amount of T3, T4 in the circulation, and that high amount of T3, T4 circulation will cause something which is known as thyroid storm. Okay, in unprepared patients, when you do the surgery, so what will happen? Patient will have tachycardia. Initially the BP will rise and then it will fall. There will be increased respiratory rate, decreased urine output, but very, very important symptom you will see is the temperature of the patient becomes very high. Okay, hyperthermia. The temperature can touch up to like 104 and 103. So during surgery, if hyperthermia occurs, one problem is, yes, we can see that it can be because of thyroid storm. Another important differential diagnosis is malignant hyperthermia. Malignant hyperthermia, I am sure if you have read about this. This is because of succinylcholine. This is a side effect of succinylcholine. Succinylcholine or succinylcholine. So how will you differentiate that this high temperature is because of malignant hyperthermia or because of thyroid storm? One thing, in malignant hyperthermia you will find muscle rigidity that you will not see in this. You will see increase in the creatinine phosphokinase that you will not see in this. You will see metabolic acidosis that you will not see in this. You will see hypokalemia that you will not see in malignant hyperthermia. And malignant hyperthermia usually occurs intraoperatively. Okay, mostly it occurs during the surgery, and thyroid storm mostly occurs in the post-op period. Mostly in the post-operative period. Okay, it's very good, Pran Himangi. CPK level is also used to differentiate. Okay, so this is how you can differentiate that this increased temperature is because of thyroid storm or because of malignant hyperthermia. The treatment of malignant hyperthermia is you will give dantrolene. The treatment of thyroid storm is mostly you will give propylthiouracil, beta blockers. These are given in intravenous form. Okay, sodium iodide, potassium iodide. Sometimes even the patient might require hemodialysis because of very high circulating T3, T4 in the body. Okay, so these are the important differences between a malignant hyperthermia and a thyroid storm. Okay, yes, EtCO2 may also be used, but EtCO2 is mainly something which the anesthesia people will see. We as a surgeon, we don't see these EtCO2 and all, so we consider these as the important differences to differentiate between a thyroid storm and malignant hyperthermia. Okay, so these are the complications, important complications of thyroidectomy. Very, very important. Every year there is a question from this. Okay, so that's why I kept this as a first question so that we can discuss this. Next step is wound exploration. Okay, you will take the patient to the OT and open up the wound, see what blood vessel is bleeding which has led to the hematoma, and you control that vessel by simply putting a ligature to it. Okay, next question. 29-year-old female, history of difficulty becoming pregnant presents, and there is Graves' disease, and TSH is low, T4 is elevated, and she elects to undergo thyroidectomy because she wants to become pregnant as soon as possible. And after she was made euthyroid, which of the following management strategies should be employed to reduce the risk of developing thyroid storm in the operating room? Okay, so you need to, like I said, you need to make the patient euthyroid for a brief period so that you can do the surgery safely. Drops of Lugol iodine daily beginning 10 days preoperatively is the true statement. Okay, that is the correct statement. Lugol's iodine will decrease the T3, T4 levels, and it also decreases the vascularity. Preoperative treatment with phenoxybenzamine, this statement is true for pheochromocytoma. Okay, this is what we do in pheochromocytoma. Preoperative treatment of propranolol for 1 week. If you want to give propranolol, give it for at least 2 to 3 weeks prior to surgery. 1 week it will not help. No role of corticosteroids in the management. So option number A is the correct statement for decreasing the risk of thyroid storm during surgery. Lugol's iodine should be started 10 days prior to the surgery. Beta blocker should be started 2 to 3 weeks prior to the surgery. And anti-thyroid drugs like carbimazole or methimazole should be started 4 to 6 weeks prior to the surgery. Okay, yes, most of you are correct. A is the correct answer. Okay, one thing I want to discuss in this Graves' disease, because last year there was question on this. Graves' disease. We know this is a case of primary hyperparathyroidism, primary thyroidism, primary thyrotoxicosis. This is autoimmune condition with the anti-TSH receptor antibody. Okay, so this is a typical example of thyrotoxicosis. All the features of thyrotoxicosis like weight loss and heat intolerance, palpitation, sweating, eye signs. Okay, all these things will be present in this. IV steroids have no role in thyroid storm. Okay, Mehak, IV steroids have no role. Anti-TSH receptor antibody. So in Graves' disease, how will you investigate? Okay, what are the investigations you will do to confirm that it is Graves' disease? Although Graves is very commonly diagnosed as a clinical diagnosis, but still you need to confirm. So first thing is you will see that the TSH will be low, T3, T4 may be high. Even if they are not high, low TSH is good enough. Then there is a test known as radioactive iodine uptake. Radioactive iodine uptake, when you give like iodine 123 to the patient, so thyroid is not taking whatever iodine you are doing, whatever iodine you are giving to the patient. Thyroid will take only a percentage of that iodine. Okay, so the normal uptake is around 15 to 30%. Okay, around 15%, but 15 to 30% is considered as normal. This will be very high in Graves. In Graves, it could be like 90%, and it will be low in Hashimoto thyroiditis. In Hashimoto's, this will be low. So this is another test. Ultrasound will not show you much. Ultrasound will just show you some enlargement, mild enlargement of the thyroid gland and increased vascularity. Because it is hyperfunctional, so obviously the vascularity will be high. And even if like this much is good enough for making the diagnosis, but suppose it is not enough, then you can go for serum TSH receptor antibody, that is serum TRAB, TSH receptor antibody. So that can also be seen. The value of this will be high in the serum. Okay, so these are the investigations which are mainly done for the diagnosis of Graves. Remember, FNAC is not required. You don't have to do a FNAC for that confirmation of Graves' disease. Okay, and this was a question, which set of investigations are required. So FNAC is not necessary. You go for these investigations. Okay, thyroid profile, radioactive iodine uptake, ultrasound, and TSH receptor antibody. Okay, nothing else you need to do in Graves. Treatment option. See, anti-thyroid drugs is one option. Radioactive iodine ablation is another option. And surgery actually is the least preferred option. Okay, so these are the three options with the patient: antithyroid drugs or ablation or surgery. Antithyroid drugs, usually we give propylthiouracil. Carbimazole is the most common drug used. Methimazole is also commonly used. PTU is not used commonly because of its side effects on the liver function. So that's why this is the drug of choice only in the first trimester of pregnancy. In the first trimester of pregnancy, this is the drug of choice. Otherwise, PTU is not commonly used. Okay, so advantage of this is, now TRAB is for Graves' disease. Okay, congenital hypothyroidism, you don't have to go for TSH receptor antibody. Okay, congenital hypothyroidism mein Rafat, TRAB antibodies are not required. TRAB is very important and very commonly used for Graves. Not for congenital hypothyroidism, you don't have to go for TRAB. Okay, RAI ablation, you use iodine 131 isotope. Okay, usually the dose is 8 to 12 millicurie. And when it goes into the body, it is given in the form of a tablet. It will release gamma and beta rays. These gamma and beta rays will destroy the thyroid. Destroy the thyroid means it will destroy the thyroid functionally. Thyroid will not be able to produce T3 and T4. But a very important disadvantage of this is, although the treatment is very good, you have to give just one dose as compared to antithyroid drugs, where patient has to take the drugs daily, mostly twice a day for 1.5 to 2 years. In this, just one single tablet or maximum one more after 4 weeks. Okay, but the problem is that sooner or later it will lead to permanent hypothyroidism. And second thing is, this option is not for everybody, because the absolute contraindication, because it is radiation, so pregnancy and lactation is absolute contraindication. Relative contraindication means in these cases you can use, but you have to use it very cautiously, like in case of children, in severe eye signs, and in arrhythmias. Okay, you may use, but try to use cautiously and don't make it as a first line treatment in these patients. Okay, so these are important things about RAI ablation. Surgery, if at all you need surgery, it will be a total thyroidectomy. And indication of this is although the least preferred option in Graves' disease surgery, but yes, in which cases it is required, if it is patient's choice. Patient does not want to take long duration of antithyroid drugs. Patient does not want to take radiation. So this is the treatment, patient's choice. Or suppose if it is causing, the thyroid swelling is causing compressive symptoms. Okay, dysphagia, dyspnea. Remember, in thyroid, whatever may be the diagnosis, if there are compressive symptoms like dyspnea, dysphagia, change in voice, then the treatment of choice is surgery. Okay, pregnant patient with failure of medical management. Patient is pregnant, you are trying to treat the patient with the antithyroid drugs, but somehow the patient is still having problem, then you go for this. And if there is any suspicion of cancer. Okay, so these are some of the indications where you go for surgery. One more thing you remember in this antithyroid drugs, that whatever drugs you are giving, along with these drugs, you will also add a non-selective beta blocker. Okay, propranolol. Initial period may you will give for the symptom control. Okay, so later on you can stop also, but yes, in the beginning you will add a beta blocker with the antithyroid drugs. Okay, so this is in brief the treatment of investigation and treatment of Graves' disease. Okay, any question if you have regarding Graves' disease, you can ask and we can discuss. Next question, a patient underwent modified radical neck dissection type 2. Okay, so this is MRND type 2. Which of the structures were preserved? D is the cranial nerve 11, that is spinal accessory. C is the internal jugular vein. A is the sternocleidomastoid muscle. Okay, so the question is MRND2 has been done, and among these three structures, which of the structures will be preserved in that? So neck dissection, which is a very important topic, and you get questions directly on the neck dissection. Also, you find neck dissections in many of the management of head and neck cancer. So you should have the basic idea about the neck dissection, that what are these neck dissections and how we should, basic understanding of this, and in which case, which type of neck dissection is done. LATS antibody, no, there is nothing like LATS antibody for which you are asking, Pooja. See, it is TRAB antibody, or some people call it as thyroid stimulating immunoglobulin, TSI. Okay, nothing like LATS I have ever heard in case of Graves' disease. Okay, because it is not something which I am telling you as bookish knowledge. These are the cases we treat day in and day out, and this is what is required. Okay, we don't ask for TRAB in all the cases. Mostly the investigation, the diagnosis is based on thyroid profile and RAIU, but still in some case of diagnostic dilemma, you can go for TRAB. That is what is practically being done, and this is what is written in books. LATS is something which is absolutely has no relevance when we are talking about Graves' disease. Okay, neck dissections. Neck dissection. Okay, initially the first type of surgery was done. I hope you know what are the levels of lymph node. Okay, cervical lymph nodes from level 1, 2, 3, 4, 5, 6 and 7. Level 1 is submental, submandibular. Submental is just below the chin, submandibular in the submandibular area. 2 is upper jugular, that is in relation to the upper 1/3 of the jugular vein. 3 is mid jugular. 4 is lower jugular. 5 is lymph nodes in the posterior triangle of the neck. 6 is anterior compartment, that is pretracheal, prelaryngeal, pretracheal, and 7 is upper mediastinal. So when we do the surgery of the malignancy in the head and neck area, we have to remove the primary tumor as well as you have to take out the lymph nodes in the neck, because the head and neck area, the lymphatic drainage is the cervical group of lymph nodes. So initially when the first surgery came, it is known as radical neck dissection. Radical neck dissection. This was given by Kreil in 1905. So in radical neck dissection, all the lymph nodes from level 1 to 5 were removed, and along with that cranial nerve 11, internal jugular vein and sternocleidomastoid muscle was also removed. Okay, to do the complete clearance from one side, so all the lymphatic tissue, lymph nodes and these structures used to be removed in radical neck dissection. Later on, decades later, the people, they realized that removing the lymph node is a good thing, but if you remove this nerve, vein and muscle, it is not giving any additional oncological benefit, and it basically increases the morbidity of the patient. So they said that the surgery should be modified. So then came modified radical neck dissection, which is commonly known as MRND. So in modified radical neck dissection, all the lymph nodes from 1 to 5 are removed, but then they started preserving the other structures. So in the initial surgery, they preserved the cranial nerve 11. Preserved. So then they called it as MRND type 1. Then they said, okay, preserve one more thing, cranial nerve 11 and internal jugular vein preserved, that is MRND 2. And then the third surgery, cranial nerve 11, internal jugular vein as well as sternocleidomastoid preserved, that is MRND 3. Okay, so these are the three types of modified radical neck dissection. Lymph nodes we are removing is same as radical, that is level 1 to 5. But then we started preserving the other structures. Nerve is present, it is 1. Nerve and vein is preserved, it is 2. Nerve, vein as well as muscle preserved, 3. Okay, so suppose the patient is if the patient is lymph node positive, means if the lymph node metastases are there, then you can go for radical neck dissection or modified radical neck dissection type 1, 2 and 3. Sorry. These days a common term given for these is comprehensive neck dissection. Okay, for lymph node positive patient, you go for comprehensive neck dissection, radical, modified radical, depending on case to case basis, 1, 2 or 3. But suppose the patient is clinically lymph nodes are not involved. Clinically as well as radiologically, the lymph nodes are not enlarged. So in these cases, in few cases you can go for follow-up. There is role of sentinel lymph node biopsy also in selected group of patients, or we can go for selective neck dissection. The selective neck dissection is known as elective neck dissection as a new term. Okay, so these are the new terms, comprehensive and elective neck dissection. So selective or elective neck dissection is the lymph nodes are clinically or radiologically not yet involved, but still looking at the primary nature of the tumor, that suppose there is a cheek cancer. Okay, the people know that cheek cancer or the tongue cancer, they spread very frequently to the lymph nodes. So you will selectively remove few group of lymph nodes which are the primary draining area of that particular tumor, and then you send it for biopsy and you will see that whether any micrometastasis has occurred in the nodes or not. Sorry. So that is selective neck dissection. In this there is supraomohyoid neck dissection, supraomohyoid neck dissection, where you will remove level 1, 2 and 3 lymph nodes. Then extended supraomohyoid neck dissection, where you will remove level 1, 2, 3 as well as 4. Then lateral neck dissection, where you will remove level 2, 3 and 4. Posterolateral neck dissection, where remove level 2, 3, 4 as well as 5. And central neck dissection, where you will remove level 6 with or without level 7. Okay, so these are different elective neck dissection or selective neck dissection. Like if I give you example, supraomohyoid is done in buccal mucosa cancer, or you can say cheek cancer. Extended supraomohyoid, tongue cancer. Lateral, pharynx or larynx cancer. Posterolateral, skin cancer on posterior scalp. And central, in few thyroid cancers. Okay, so these are the important things about neck dissections. If you have any question related to the neck dissection, you let me know. Okay, so how will you understand? See, suppose the patient is having tongue cancer and the patient is also having nodes in the neck. So then you will remove the tumor, primary tumor, and you will do any of these surgeries. Okay, mostly people do modified radical these days. But suppose patient has tongue cancer and clinically and radiologically lymph nodes are not involved, then you will do extended supraomohyoid. Okay, so that is the difference between lymph node positive and lymph node negative. So basically lymph node negative means N0 patient. So for N0 patient, either you will do follow-up or you can go for sentinel lymph node, although in the head and neck cancer sentinel lymph node is very new. Sentinel lymph node has a very proven role in breast cancer, in melanomas, in penile cancer, but in head and neck cancer this is just some upcoming thing. or you can go for selective neck dissection or elective neck dissection, which we have discussed. Extended radical neck dissection is when you remove any other structure apart from radical neck dissection. Okay, so that is radical neck dissection plus any other, you can say the lymph node or structure, then it is extended radical. So that is too radical, and very few cases may you have to go for this, because this surgery is too extensive. So people generally don't follow this unless there is no distant metastasis and the lymph node is involving, suppose, skin or some other muscle, strap muscle. So if you are removing that also, then it becomes radical. Okay, so radical plus any other lymph node or any other structure if you are removing, then it becomes extended radical. Okay, so these are the neck dissection. In the question which was given, it is MRND type 2. So in type 2, preserved structures are, what are the preserved structure? You will preserve the nerve and vein, B and C. B and C. All of the following are indications for surgical treatment of secondary hyperparathyroidism except. Okay, so hyperparathyroidism is a very important topic. Parathyroid itself is a very important topic. Okay, so we'll discuss in one go all the things about parathyroid. Okay, parathyroid, basically parathyroid produces, there are 4 parathyroids, and parathyroid produces PTH hormone, parathyroid hormone. Parathyroid hormones maintains the serum calcium level. So it maintains the serum calcium level, it absorbs the calcium from the bone and from the kidney, it will cause more absorption, and also from the GIT indirectly it will affect, and tries to maintain the serum calcium level. So if this serum PTH is high, increase in the serum PTH is known as hyperparathyroidism. Hyperparathyroidism, HPT. So this is the topic which we have to see, hyperparathyroidism. Yes, A is the answer. Hyperparathyroidism can be primary, secondary or tertiary. The question is about secondary. Primary means when there is some problem in the parathyroid gland itself, like parathyroid adenoma, parathyroid hyperplasia or parathyroid carcinoma. Okay. Adenoma means among all the 4 parathyroid, if one of the gland is, suppose these are the normal, and one of the gland is large and produces excessive PTH. In hyperplasia, all the 4 glands will be large and they produce excessive PTH. In carcinoma, one of the gland will have malignant changes. Okay, so adenoma is responsible for more than 80% of the primary hyperparathyroidism. Secondary is because of hypocalcemia in the body. Because of hypocalcemia, patient has increased PTH formation. Because of hypocalcemia, there is increased parathyroid hormone. So hypocalcemia occurs mainly because of chronic renal failure or vitamin D deficiency or malabsorption. Tertiary is when there is prolonged secondary hyperparathyroidism, the gland becomes autonomous. The gland becomes autonomous because of prolonged secondary hyperparathyroidism, and then it will keep on producing excessive PTH. No matter calcium value is normal or low, it will produce PTH. So that is primary, secondary and tertiary. Now if we see primary hyperparathyroidism, mostly this is the cause. Okay, 80% is this cause more than 80%. In fact, hyperplasia is just 10 to 15%, and carcinoma is rare, just 1 to 2%. Okay, so in carcinoma, see, if you see, normal serum calcium value is 9 to 11 milligram per deciliter. In parathyroid adenoma or parathyroid hyperplasia, serum calcium will be high. High means it will be like you can say 12 to 14 milligram per deciliter. But in carcinoma, the value will be very high. Serum calcium can be like 14 to 20 milligram per deciliter. So very high serum calcium level, one should think about carcinoma. Okay, so diagnosis is not very difficult. If you suspect it to be a parathyroid disorder, you will see increase in the serum PTH, increase in the serum calcium, as well as increase in the urinary calcium. Okay, PTH value normal is 15 to 65 picogram, which will be very high in case of hyperparathyroidism. So we know, suppose the patient comes and with the increased calcium level, you suspect it to be parathyroid, you check the serum PTH, PTH is also high. Now you are suspecting, yes, it could be a parathyroid disorder, and mostly the parathyroids are parathyroid adenoma. So now you want to know that among all the 4 parathyroid, which parathyroid is the culprit and which is producing excessive PTH. So localization is a very important issue in the parathyroid, because these days we don't give a big incision like we give for the thyroid, because earlier when the diagnosis of parathyroid adenoma was made, people used to give a big incision from one sternocleidomastoid to other. They used to see all the 4 parathyroid, and among all the 4 parathyroid, the one which was enlarged, they used to take out that. Okay, but now because of the better preoperative localization technique, we don't give that big incision. We'll give just a 2 centimeter or 2.5 centimeter incision, and we'll take out that involved gland. So for this, you need to know preoperatively very precisely that which parathyroid is involved among all 4. So for that, the investigation of choice is, yes, very good, Himangi, technetium 99 sestamibi scan. Okay, this is the investigation of choice for localization. You will very nicely see that the parathyroid is one of the parathyroid will take up this sestamibi. Initially, all the 4 parathyroids will take this scan, this nuclear isotope, and later on it will stay only in one, and from the rest of the 3 parathyroids it will wash away. So once they have asked that which kind of cells of parathyroid takes this sestamibi, so that is you can say oncophilic or oxyphilic cells. Oxyphilic cells of parathyroid will take up this sestamibi. Okay, so now we need to know the treatment. In treatment, when will you go for surgery? Indication for surgery. Indication for surgery is either the patient is having symptoms. These days patients are mostly having symptoms like fatigue or bony pain and polyuria, polydipsia. These are the symptoms. In asymptomatic patient, when you are supposed to do surgery, this is important. If the age is less than 50 years, if the serum calcium is more than 12 milligram per deciliter, that is more than 1 milligram above the normal value. If there is decrease in the bone mineral density, and if there is decrease in the kidney function test like GFR less than 60 ml per minute. Okay, so these are the 4 important indications in asymptomatic patient when you will do surgery. If the patient is having symptoms, then so you have to do surgery. Now the surgery for parathyroid adenoma is, you will give an incision there right in front of that adenoma, and you will take out that gland. Okay, take out the involved gland. So that is known as minimal invasive parathyroidectomy, because you are not giving a big incision, you are giving just 2 centimeter incision. Minimal invasive parathyroidectomy for parathyroid adenoma. Now again, one question comes here is, let's see, this parathyroid gland, these are very small, so very small gland, if it becomes enlarged, it is still small. So when you remove this from a small incision, and there are parathyroid generally looks yellowish brown, and there are other structures in that area that will also look yellowish brown, like lymph nodes, like fat globules. So when you remove a swelling from that area, how will you make sure that the thing which you have removed is parathyroid only and not something else? Decrease GFR, because it affects the renal function. Okay, it affects the renal function. Okay, Ramnesh, it affects the renal function. Okay, so minimal invasive parathyroidectomy, how will you do the confirmation? Confirmation of removal. Confirmation of removal is, either if you have the facility available, go for a frozen section. Go for frozen section. Otherwise, you will see drop in serum PTH more than 50% of the baseline value 10 minutes after the removal. Okay, just a moment. This is known as Miami criteria. Okay, this is known as Miami criteria. Okay, so Miami criteria is important question. Confirmation of removal, these are the two main options which are done for confirmation. For parathyroid hyperplasia, where all the 4 glands are enlarged, you have 2 options. You have to go for big incision, that is known as bilateral neck exploration, and then either you remove 3.5 gland or you remove all 4 glands, but then from all the 4 glands, the one gland which is looking better than the other 3, you take half of one gland and put it back in the body, not in the neck, but in the brachioradialis muscle of the non-dominant forearm. So that is autotransplantation in brachioradialis muscle. Suppose a person is right-handed, so put in the left brachioradialis. If the patient is left-handed, then put in the right brachioradialis. Okay, and parathyroid carcinoma. See, carcinoma may usually, normally the parathyroid glands are not palpable, but in carcinoma, the gland may become clinically palpable. And the treatment is, you have to remove not just the gland, but the ipsilateral thyroid also. So that is en-bloc parathyroidectomy. En-bloc means you will remove the things surrounding that involved gland. En bloc parathyroidectomy, which needs a ipsilateral hemithyroidectomy. Yes, so these are the important things which you are supposed to know in parathyroid. Now, treatment of secondary hyperparathyroidism. Mostly the treatment is calcium supplementation. Indication for surgery. Surgery may the same thing, bilateral neck exploration, and then 3.5 or all 4 with auto transplant. But when to go for surgery? If the serum PTH is more than 800, if the gland is more than 1 centimeter, if the product of serum calcium multiplied by serum phosphate is more than equal to 70, in our question it is less than 70. If there is calciphylaxis, if there is severe pruritus, and if there is intractable anemia. Okay, so last two are mainly for the CRF patient, severe pruritus and intractable anemia. So removing of the parathyroid helps in those cases. Okay, so these are some of the indications when you have to go for surgery in secondary. Otherwise, BN is bilateral neck exploration. Okay, like it's a same kind of incision which you give for total thyroidectomy, bilateral neck exploration. And that was minimal invasive parathyroidectomy where you used to give very small incision. Now, treatment of tertiary hyperparathyroidism is surgery in all cases. Okay, surgery is same, this one. Okay, surgery in all the cases. PTH level more than 800. Normal it is 15 to 65 picogram. It is more than 800. Okay, in few books it is written as 500. Mostly it is written as 800. Okay, so these are the important things which you are supposed to know in the parathyroid. Calciphylaxis is Karun when there is deposition of calcium in the subcutaneous area, and that can lead to pain, that can lead to itching. So those are painful nodules in the subcutaneous area, development of deposition of calcium, that is calciphylaxis. Okay, so answer here is A. Calcium phosphate product of it should be more than 70, not less than 70. Next question. 33-year-old female and swelling in her right parotid. Biopsy says mucoepidermoid carcinoma, and you consent the patient for resection, and at least she has to go for superficial parotidectomy. Which of the following intraoperative finding would sacrifice the facial nerve? Okay, so the correct answer here is the facial nerve should always be preserved regardless of intraoperative finding. Okay, facial nerve we have to preserve. The only indication it is removed is facial nerve is sacrificed if tumor is directly infiltrating the nerve. Infiltrating the nerve. Okay, direct infiltration. Encasement of facial nerve is not an indication. See, you should know the difference of infiltration and encasement. Suppose this is the cut section of facial nerve, and suppose this is the tumor. So tumor is, this is involvement, yeah, infiltration. Suppose this is the facial nerve and the tumor is encasing, means it is just touching, it is like this. So it is encasement. it has not gone inside the nerve. It is closely related, touching the nerve, abutting the nerve, but it has not gone inside. Okay, so encasement or abutment is different and infiltration is different. So if it is causing infiltration, then in this case, so we need to take out that part of the nerve which is infiltrated. But in case of encasement, you can preserve facial nerve and take out the tumor without sacrificing the nerve. Okay, I guess I had answered your question, Himangi. Why not C? Because encasement and infiltration are different. Brachioradialis in, autotransplantation in brachioradialis, Faizan, the basic concept is, see, suppose you are leaving 3.5 gland in the, and 3.5 gland and leaving half of the gland back in the neck. So suppose in future, the remaining half gland is producing excessive PTH and you want to go again in that area and you want to do surgery again. So once you have already done surgery, you are going to operate in an already operated neck. So next time when you go to take out that half of the gland, there will be lots of adhesions, lots of fibrosis, and the surgery will be very difficult. As compared to when you remove all the 4 and put half of the gland back in the brachioradialis muscle, suppose in future that causes any problem, it is very easy to take out the pieces from the brachioradialis. So that's why autotransplantation option is more preferred by the people, because the future surgery will be easy if you put the pieces of parathyroid in the brachioradialis as compared to leaving it back in the neck. Okay, so the facial nerve should be preserved regardless of the intraoperative finding. Now, one question they mostly ask during the exam about what are the risk of nerves at risk in parotid surgery and nerves at risk in you can say submandibular surgery. Parotid surgery, the nerves at risk are facial nerve, auriculotemporal nerve, and greater auricular nerve. Facial nerve, we all know if there is injury to the facial nerve, that will cause different symptoms. There will be deviation of the mouth to the other side, inability to close the eyes, all those problems. Auriculotemporal nerve injury will lead to something known as Fraze syndrome, and greater auricular nerve injury will cause loss of sensation in this part of the cheek. So that is the problem will occur if these nerve injuries occur. Submandibular surgery, there will be nerves at risk are lingual nerve, hypoglossal nerve, and marginal mandibular branch of facial. Marginal mandibular branch of facial nerve. Okay, now if we see salivary gland tumors, around 70% of the tumors, they arise from parotid, 22% from submandibular gland, and 8% from sublingual and minor. So majority of the tumor, they arise from parotid. But if we see the benign and malignant tumors in these glands, parotid, mostly more than 80% are benign, less than 20% are malignant. Submandibular and sublingual, 50% benign, 50% malignant, and minor, 10% benign, 90% malignant. Okay, so most of the minor salivary gland tumors are malignant. Two important benign tumors are pleomorphic adenoma and Warthin's tumor. Warthin's tumor, which is also known as adenolymphoma or papillary cystadenoma lymphatomesum. Two important malignant tumors are mucoepidermoid carcinoma and adenoid cystic carcinoma. One important thing which you should remember about adenoid cystic carcinoma is it has perineural invasion. It is the most common tumor of submandibular, sublingual and minor gland. Pleomorphic adenoma is the most common tumor of overall salivary gland and parotid. Okay, so anything, if you have any query in the salivary gland, anything you want to ask, feel free to ask. Okay, so D is the answer. You should not sacrifice a gland unless the tumor is directly infiltrating into the gland. A 63-year-old female and there is lump on both the sides. FNAC is non-diagnostic and she undergoes total thyroidectomy. Final pathology reveals a 2 centimeter tumor with oxyphilic cells. Which of the following is the most appropriate post-surgical management of this patient? Oxyphilic cells mostly you will find in Hurther cell cancer, Hurther cell carcinoma. So let's discuss in this session, we'll discuss the management of thyroid tumors and what we are supposed to do in the post-surgery or the post-thyroidectomy status. Okay, so let's discuss all the important things about thyroid malignancies because that is also an important topic. Any question in the meanwhile, whatever topics we are doing, if you have any question, any confusion, you can type and we can discuss that also. First we'll see papillary thyroid cancer. This is most common, more than 80% of thyroid cancers. More common in females, usually younger, 20 to 40 age group. There are lots of mutations you will see in different tumors and all the thyroid tumors also many mutations. We'll see the most common mutation in papillary thyroid cancer is BRAF gene mutation. Okay, the risk factor is mainly radiation, history of radiation in the past, thyroglossal cyst, and Hashimoto is also a risk factor. Microscopically important things, orphan NEI nuclei where there is like empty type of nucleus, some MoMA bodies. This tumor is multifocal and it is non-encapsulated. It does not have a capsule on it. Osteitis fibrosa cystica is in case of parathyroid disorders when the increased PTH takes the calcium from the bone becomes weak. That is known as osteitis fibrosa cystica. Okay, the weak bone because of taking the calcium. So that is the same as decreased bone mineral density. The bone becomes weak. That is osteitis fibrosa cystica. Okay, Aishwarya. Now see, the spread can occur by all the routes, local, lymphatic as well as hematogenous, but the most common route is lymphatic. Okay, clinically most of the patient presents as thyroid nodule And all the thyroid malignancies are mostly euthyroid. They are mainly euthyroid. They don't produce excessive, T3, T4. So see, sometimes what happens, suppose this is a thyroid gland. The patient is having a very small papillary thyroid cancer focus. So it is like less than 1 centimeter. Patient does not know that there is any problem in the thyroid. But this has already spread to the lymph nodes present at the side of the neck, and the patient comes with this problem. Patient comes and says that there is a swelling at the side of neck. So people used to take FNAC from this, and FNAC suggests that there is thyroid features in this swelling. So initially people thought that this is an ectopic thyroid tissue, but later on they come to know that this is not ectopic. In fact, this is a lymph node metastasis from an occult papillary thyroid cancer. This condition is known as lateral aberrant thyroid. Okay, very, very important question. What is lateral aberrant thyroid? This is a lymph node metastasis from occult papillary thyroid cancer. Okay, yes, very good, Mehak. Okay, investigation. We go for FNAC of the lymph node. Ultrasound neck is good enough. You don't have to do CT in all the cases. CT is required only if the ultrasound shows that there is extrathyroidal spread, then only you can go for CT. Serum thyroglobulin is the tumor marker. Now treatment. Treatment is, if the tumor is less than 1 centimeter, no lymph node involvement, then you can, this tumor is very good, and many times people, they don't do anything, active surveillance also. Or you can go for a hemithyroidectomy. So less than 1 centimeter tumor, you can wait and watch also, or you can go for hemithyroidectomy. But if it is more than 1 centimeter or less than 1 centimeter with some suspicious lymph node, in these cases we have to do either a hemi or a total thyroidectomy. Either hemi or total. Now when to do what? Let's see, if there is distant metastasis, if there is lymph node metastasis, if the tumor is going outside the thyroid, extrathyroidal extent, if the size of the tumor is more than 4 centimeter, if there is bilateral nodularity, on both the sides there are nodules, if it is a high grade tumor, and if there is prior history of radiation, if any of these are present, you go for total. Okay, if all of these are absent, then you go for hemi. Okay, so there are many cases where you can go for a hemithyroidectomy in case of papillary thyroid cancer, because this tumor is relatively much better tumor than many other cancers in the body, and it has the best prognosis among thyroid cancer. Best prognosis among thyroid cancers. The 10-year, in fact, in this case, they check the 20-year survival. Okay, 20-year survival in these cases is more than 90%. Second tumor is follicular thyroid cancer. Okay, 10 to 15%. This is also seen more common in females, although the age group is slightly older. Most common gene mutation here is RAS gene. Risk factor is multinodular goiter or iodine deficiency. Spread most commonly hematogenous, that is blood-borne. Mostly it goes to bone, where it causes pulsatile osteolytic bony metastasis. pulsatile osteolytic bony metastasis. Now investigation is same as papillary thyroid cancer. Green ink on left side, all absent. All of these things are not there, then you can go for Hemi. I mean, if there is no distant metastasis, no lymph node metastasis, size less than 4, no extrathyroidal, no bilateral nodularity, if it is low grade, no history of radiation, then you can go for hemithyroidectomy. If any of these things are present, then you go for total thyroidectomy. Okay, Faizan. If these things are not there, you may go for a hemithyroidectomy. If any of this is there, then though you have to go for total thyroidectomy. Okay, investigation is same, but the problem is that when you do FNAC, most common site of metastasis in papillary thyroid cancer is mostly liver, and in follicular thyroid cancer is bone. Okay, liver, lungs are in papillary thyroid cancer, bone in follicular thyroid cancer. FNAC, when you do FNAC will tell you that this is follicular neoplasm, because FNAC cannot differentiate that whether it is follicular carcinoma or follicular adenoma. So after this you go for a same side hemithyroidectomy. I'll not tell you very confusing thing. I'll tell you very straightforward. After doing a ipsilateral hemithyroidectomy, you send the specimen for histopathological examination. In histopathological examination, they will see capsular or vascular invasion. If this is present, then you will go for completion total thyroidectomy, because half you have removed. Now if it is present, it means it is follicular carcinoma. So you have to go for remaining you have to go for removal of the other half. But suppose it is absent, it means it is follicular adenoma. Follicular adenoma is a benign thing. No further treatment is required. No further treatment. Okay, and there is a type known as Hürthle cell cancer. It is 3% of the thyroid malignancy. It is just a variant of follicular thyroid cancer. Okay, अभी के time पे just remember it is just a variant of follicular thyroid cancer. It is a little bit more aggressive as compared to follicular thyroid cancer. You will see oxyphilic or auxentic cells. Investigation management is same as follicular thyroid cancer. It is same as follicular thyroid cancer. So now see papillary thyroid cancer, follicular thyroid cancer, and Hürthle cell cancer. This is what I am discussing. Okay, Yasir Arafat. These are known as differentiated thyroid cancer. Differentiated thyroid cancer. True cut biopsy we don't do in thyroid suspicious thyroid tumors and all, because true cut biopsy can lead to bleeding. Okay, and this is the area where the bleeding could be significant. So at your level, just remember true cut biopsies are not done in thyroid. The minimum biopsy we do in thyroid is hemithyroidectomy. So in differentiated thyroid cancer, if the lymph nodes are involved, then you will go remove level 6 and do the modified radical neck dissection on the same side. But if lymph nodes are not involved, you can go for follow-up. You don't have to remove lymph nodes in each and every case of differentiated thyroid cancer. Okay, these are good cancers. Papillary follicular health are considered as good cancers. In the risk factor for follicular thyroid cancer, it is multinodular goiter and iodine deficiency. Okay, Mehak. Okay, third tumor we'll see anaplastic thyroid cancer. Anaplastic thyroid cancer is just 1 to 2% of the thyroid malignancies. Male-female incidence is same, and mostly it involves elderly people. Okay, and a most common gene mutation is P53. So anaplastic thyroid cancer, most common spread is local. Okay, although it can spread by lymphatic route hematogenous, but mostly it involves the local structures, like it can involve the trachea, esophagus, recurrent laryngeal nerve, larynx. So mostly it involves local structures. What is level 1 involved? So this is what I am saying. No, so that's why you are removing modified radical neck dissection. In modified radical neck dissection, level 1 to 5 all are removed. So if lymph nodes are involved, you will remove level 6 as well as modified radical neck dissection. But if the lymph nodes are not involved, you don't have to remove any lymph node. Okay, Arafat. Isn't FNAC avoided in follicular cancer? Shreya, how will you know that it is follicular cancer? The patient comes to you with a swelling in the thyroid gland. How will you know it is follicular cancer? Who is going to tell you that this is follicular cancer? Okay, it is FNAC only, which will tell you this is papillary, this is follicular, this is medullary, this is anaplastic. So it is after the FNAC you will know that which kind of malignancy you are dealing with. Patient will not come to you and he will or she will say that I am having follicular cancer and please don't do FNAC on me. Because FNAC was done, that's why patient knows that he or she has some follicular tumor. Now that follicular tumor is adenoma or carcinoma. For that you will do a hemithyroidectomy first and then you will make the diagnosis that whether it is carcinoma or adenoma. Okay, why FNAC should be avoided in these cases? Okay, it is absolutely not true that FNAC is avoided. It is in fact the investigation of choice in thyroid malignancies, FNAC. What else you will do if not FNAC? Okay, and this has you can say the poorest prognosis. Okay, mortality rate is you can say almost 98 to 100%. Okay, so the treatment is mainly limited to the palliation. Mainly palliation like radiotherapy, chemotherapy. The only surgery you do in these cases is for the palliation, like just remove the isthmus so that it will not compress the trachea or esophagus. Okay, palliative surgery like isthmectomy. In question like next step in the treatment, like what is the question in which the next step of the treatment you are asking? Okay, Prajwal Yadav. I don't know. See, have you read this in the book that FNAC is avoided, or any faculty has told you that FNAC is avoided? Because this is the first time anybody is asking me that FNAC is avoided. I mean, there is some major confusion at your level. Who told you that FNAC is not done or avoided, or whatever? Why this confusion? This is the first time I am thinking or I am listening about this kind of confusion. What is your confusion? What is your confusion? FNAC is avoided, then you tell me if FNAC is avoided, then how will you make a diagnosis that this is follicular cancer? Patients are euthyroid. Okay, they will come to you, they will say that Dr. Saab, I have this swelling in my neck. You will ask the patient to swallow and you will make sure that this is the swelling arising from the thyroid gland. Now, how do you know that this is follicular cancer? If not FNAC, then who will tell you if it is follicular cancer? Okay, those who are saying that FNAC is avoided. Tell me, how does the patient knows, or how do you know that it is follicular cancer? It is not, Shreya, the question is not that. The question is, in which type of thyroid cancer FNAC is not helpful or FNAC is not diagnostic. Okay, because FNAC will tell you it is follicular neoplasm, it will not tell you it is follicular cancer or follicular adenoma. For that you need to go for hemithyroidectomy. Okay, for that you need to go for hemithyroidectomy. There are many cancers, when you do FNAC, it will tell you it is papillary thyroid, it is medullary thyroid, it is anaplastic thyroid. Okay, and there are few cases which will tell you it is follicular neoplasm. Neoplasm means it could be a adenoma or it could be a carcinoma, but FNAC cannot differentiate that whether it is adenoma or carcinoma, because to differentiate these you need to look for capsular and vascular invasion, and capsular and vascular invasion it is not possible to see on FNAC. So that's why after this you will go for a ipsilateral hemithyroidectomy, and now you send the specimen for the proper histopathological examination, which will show you that if there is capsular or vascular invasion present, it is cancer. If it is absent, it is adenoma. Okay, but you have to do FNAC to know that it is follicular neoplasm. FNAC is not avoided, it is not contraindicated. The only thing is FNAC will not tell you the definitive thing that it is cancer or adenoma, but it will tell you it is follicular. Okay, in PTC, in papillary, in medullary, anaplastic, it will directly tell you that yes, this is papillary thyroid, yes, this is anaplastic thyroid, yes, this is medullary thyroid. In follicular, the problem is it will tell you it is a follicular tumor, it could be adenoma or it could be carcinoma. For that you do a ipsilateral hemithyroidectomy and send for histopathology. Yes, FNAC cannot tell it is adenoma or carcinoma, but that does not mean that FNAC is out of the picture. FNAC is at least telling you it is follicular something, and then you do something more to make sure it is carcinoma or adenoma. Okay, so it is not avoided, it is not contraindicated. The only thing is it will not tell you the exact diagnosis. For that you need to do something more. Yes, so anaplastic thyroid, these are the important things. Fourth is medullary thyroid cancer. Medullary thyroid cancer is 3 to 5% of the thyroid malignancies. Medullary thyroid cancer arises from the parafollicular C cells. Parafollicular C cells are basically neuroendocrine cells, so you can say this is a neuroendocrine tumor. Most common gene mutation is red gene. FNAC in these cases will show amyloid stroma. This tumor is not rising from the follicular epithelium, so that's why in these cases serum thyroglobulin is not the tumor marker. The tumor marker is calcitonin and CEA. And treatment, remember, in these cases, in medullary thyroid cancer, no matter tumor is small or big or whatever, you always have to go for total thyroidectomy. Total thyroidectomy. With level 6 you have to remove in all the cases. Level 6 or maybe 7 in all the cases, plus minus MRND. If lymph nodes are involved, go for MRND. If lymph nodes are not involved, then at least remove level 6 and 7. Okay, so level 6 and 7 you have to remove in all the cases. Total thyroidectomy you have to do in all the cases. And then one more tumor, that is lymphoma of thyroid. That is very, very rare, less than 1%. And it is mostly non-Hodgkin's lymphoma, B cell type. To be more specific, it is diffuse large B cell lymphoma. DLBCL is diffuse large B cell lymphoma. That is the most common lymphoma in thyroid. Treatment is mainly chemotherapy. Okay, you don't have to do surgery in all the cases. Surgery may be even after chemo if there is residual tumor, or if the tumor is causing compressive symptom, then you'd go for surgery. But the mainstay of treatment in case of lymphoma is chemotherapy. Okay, so any question in the thyroid malignancy? If you have any question, any confusion, any doubt? Okay, any doubt? Yes, R-CHOP is a regimen. Okay, rituximab, cyclophosphamide, hydroxy, daunorubicin, oncovin, prednisolone. This is the regimen, R-CHOP. Post-surgical evaluation. After you have done the surgery, what you are supposed to do in differentiated thyroid cancer. Differentiated means papillary, follicular and Hürthle. Okay, so in these cases, the first thing you will do is suppress the TSH suppression. Okay, keep the TSH to the low level. The goal is, see, normally TSH is 0.5 to 5 milli international unit per liter. So you don't have to keep in this range. Goal of TSH in low risk, keep the TSH to 0.5, and in high risk of recurrence, keep it to 0.1. Okay, this is, I am coming to this. Most common spread in medullary thyroid is lymphatic again. Okay, then you see the serum thyroglobulin level. If serum thyroglobulin is more than 2 nanogram per ml, means either there is a residual tumor or there is recurrence. Okay, so to see this residual tumor or recurrence, get the CT or MRI done. On CT MRI, if that residual or recurrent is resectable, then do the surgery, resect it. If it is unresectable, then go for radioiodine scan. Radioiodine scan will show you that there is good uptake or poor uptake. If there is good uptake, go for RAI ablation. RAI ablation, where you will use iodine 131, usually 30 to 300 millicurie dose is required. If there is poor uptake, go for external beam radiotherapy. External beam radiotherapy means where the radiation comes and focuses on the body. That is external beam radiotherapy. Okay. And if there is persistent or recurrent locoregional or distant metastasis, you have given ablation, still there is persistent or recurrent locoregional or distant metastasis, then you go for some special type. It is not conventional chemotherapy, kind of you can say immunotherapy, targeted therapy. Lenvatinib. Yes, lenvatinib. sorafenib pembrolizumab. Okay, so even after doing radioactive ablation or external beam radiotherapy, still there is some tumor or the recurrence of something, then you go for these medications. Okay, so now you have some idea that when to give ablation, when to give chemotherapy. It is not necessary to give chemotherapy in every case. Only in selected group of patients like this, the chemotherapy is required. Now the last line. In medullary thyroid cancer, radioiodine scan and radioactive iodine ablation has no role. BCG immunotherapy is used mainly in cases of bladder tumor, urinary bladder tumor. There is question, we'll discuss that. There it is mainly used. Okay, urinary bladder tumor, when you do a TURBT, after TURBT we use this, we'll discuss. It has no role because medullary thyroid cancer arises from the parafollicular cells, and parafollicular cells has nothing to do with the iodine. So in medullary thyroid cancer, for advanced disease, either you give external beam radiotherapy or you give chemotherapy drugs like vandetanib or cabozantinib. Vandetanib and cabozantinib. Okay, so these are important things about thyroid malignancies. Okay, if you have any question in thyroid malignancies, you can ask. Okay, so there is 2 centimeter oxyphilic cells. Which are the following most appropriate post-surgical management? Chemotherapy, external beam radiotherapy, radioiodine, none of these things are required. No further treatment. Small tumor and looking at the information, no further treatment is indicated. 11-year-old girl presents to your office because of lesion on the tongue. Mother has past history of total thyroidectomy. Histology pictures, Yasir, let me just see if my images are there on this desktop. See, this is a papillary thyroid cancer. Okay, papillary thyroid cancer. You can see these cells, large cells, hollow inside. These are orphan NEI nuclei. These cells are orphan NEI nuclei. You can see orphan NE is a cartoon character, like her eyes, empty, orphan NEI nuclei. Okay, and these things are Samoma bodies. Okay, so this is important in papillary thyroid cancer. Samoma bodies and orphan NEI nuclei. Then you can see this arrow is showing basically capsular invasion in follicular thyroid cancer. Okay, follicular thyroid cancer, capsular invasion. Another picture I have, this is better picture. You can see the capsular invasion. Okay, so this is follicular thyroid cancer. This is not that important. And another important is this. This part is amyloid stroma. So amyloid stroma you will see in medullary thyroid cancer, amyloid stroma. Okay, so basically papillary and medullary, these two are important. This is also amyloid stroma. Important histopathological pictures in papillary and medullary. Okay, locoregional part, Kajal. This is what you are asking. See, suppose these are the things you have done. Okay, if it is surgically possible to remove, you have removed. Suppose surgically it is not possible to remove that residual tumor or the recurrent tumor, then you are giving either a ablation or external beam radiotherapy. Suppose after giving ablation or external beam radiotherapy, still the disease is present, so that is persistent. Or suppose after giving these things, there is recurrence of the disease, so that is recurrent. Locoregional means in the neck or distant metastasis like bone, liver or lung. So persistent or recurrent local disease or persistent or recurrent distant metastasis, then in those cases you have to give these medication, lenvatinib, sorafenib or pembrolizumab. Okay, after doing your basic treatment, if the tumor is still there, if the tumor recurs in the local area or in the some distant area, then you have to give these medications. Okay. So where were we? Okay. Which of the following tests you perform? Okay, so this is basically on the tongue. There are multiple these nodules you will see. These are basically mucosal neuromas. Mucosal neuromas which you will find in Men's syndrome. So let's discuss very quickly something about Men's syndrome. All the important things which you are supposed to know in Men's syndrome. Multiple endocrine neoplasia. First we'll see Men's syndrome 1, that is autosomal dominant condition. There is MEN1 gene mutation, MEN1 gene which is located on chromosome 11. This is also known as Wermer syndrome. Wermer syndrome. So MEN1 syndrome has 3 tumors, all the 3 tumors starting with P, that is parathyroid adenoma or hyperplasia. Another P is pancreatic neuroendocrine tumor. Another P is pituitary adenoma. So now we'll see in this the chances of which tumor has maximum chances in a MEN1 gene patient, I mean MEN1 syndrome patient. This in 90%, this 40%, and parathyroid adenoma in 30% of the MEN syndrome patients. Question is, any pituitary adenoma can occur, but the most common pituitary adenoma associated with MEN1 is prolactinoma. Similarly, pancreatic neuroendocrine tumor, the most common pancreatic neuroendocrine tumor associated with MEN1 syndrome are non-functional tumors. Non-functional tumors like the tumors which secrete pancreatic polypeptide or neurotensin. But if they ask most common functional pancreatic neuroendocrine tumor associated with MEN1 syndrome, then it is gastrinoma. Gastrinoma. Okay, now we'll see something. Maybe these are the things you already know. Let's see something which you probably don't know. That suppose a newborn comes in the family. Newborn comes in MEN1 family. So now we know that the disorder is autosomal dominant, means 50% of the offsprings will have this problem, 50% will not have this problem. So when this MEN1 newborn comes to the family, now the suppose parents will come to you and they will show that, okay, this is one new member of the family, and in our family this MEN1 syndrome is there. So what should we do, and how to make sure that the child does not have this? Okay, so you do the gene testing of MEN1 gene which is available. Suppose it is negative, means mutation is not present. It means the child is lucky one, he does not have the mutation, so he will not develop MEN syndrome. But if the gene testing is positive, positive means he will develop those tumors sometime or other in his life or her life. So now the parents will ask, okay, what we are supposed to do, how to, what should we do so that the child does not develop tumor? Okay, so this is genetic makeup. You cannot change the genetic makeup of the patient or the child, but yes, you can identify the tumor at an early stage and you can treat at an early stage. So that's why there are screening guidelines. Screening. So screening guidelines are, you have to do certain blood tests every, you can say 1 to 3 yearly. 1 to 3 yearly you have to do this blood test. When are you supposed to start these blood tests? At 5 year, 8 year and 20 year. Remember like this, 5 years the top thing what comes, pituitary. So you will start pituitary screening. At 8 years, parathyroid screening. You will begin at 5 years pituitary screening, 8 years parathyroid screening, 20 year pancreas screening. Okay, so the blood test should be done at this time, like you will from 5 years every year you will check the serum prolactin, serum LH, FSH, all these levels. From 8 years every year you will check the serum calcium, serum PTH values. From 20 years every year you will check the serum gastrin level, serum glucagon level, VIP levels. Okay, so these are the important guidelines. Just one exception or one important thing, that pancreas screening you will start at 20 years except the screening for insulinoma. Insulinoma, which is a pancreatic neuroendocrine tumor, that you will start early at 5 years, because insulinoma can occur at early stage. Rest of the things are like this. Okay, so blood test every 1 to 3 years, starting from 5 years pituitary, 8 years parathyroid, 20 years pancreas. Okay, this is more than enough. There are guidelines for, you can say, MRI brain every 3 to 5 yearly, starting at 5 years. Starting at 5 years of age. And CT or MRI of abdomen, that is for pancreatic tumors, every 2 to 4 years, starting at 20 years of age. So this is all the screening guidelines, the blood tests, the radiological investigation, when to start, how frequently it is done. So this is the screening for MEN1. Find the tumor at early stage, treat at early stage. Next syndrome we'll see is MEN2 syndrome. MEN2 syndrome is also autosomal dominant. The gene mutation is red gene. Red gene which is situated on chromosome 10. Okay, so in MEN2 there are two types. 95% of MEN2 are MEN2A. Just 5% are MEN2B. MEN2B. So in MEN2A, the tumors, common tumors which are there, one is parathyroid adenoma, or hyperplasia. Then medullary thyroid cancer and pheochromocytoma. Then 2B, which is also known as MEN3 these days. MEN2A is known as Sippel syndrome. MEN2B or MEN3, which is known as mucosal neuroma syndrome. In these, there is medullary thyroid cancer, pheochromocytoma, and multiple benign mucosal and GI neuromas. Mucosal and GI neuromas, these are benign small tumors, like the picture which you have seen on the tongue, there are multiple small nodules. So those were benign neuromas on the mucosa, that is on the tongue. Okay, in MEN2A, parathyroid is just 10%. Medullary thyroid cancer is almost in 100% in both the cases. Pheochromocytoma is like 40 to 50%. Mucosal GI neuroma is again 95% of the times. Okay, so what we are supposed to do in these cases, I mean, if the newborn comes in MEN2 family and gene testing is positive. Negative, it means the child is lucky, let the child live. Positive means not that lucky. So in these cases, because medullary thyroid cancer is happening in everybody if there is mutation, so that's why you will not wait for the cancer to develop, you will prophylactically remove the thyroid. The Sippel syndrome is MEN2A. MEN2B is this. Sippel syndrome is MEN2A. Sippel is MEN2A. Okay, Mehak. Okay, so if gene testing is positive, you will go for prophylactic thyroidectomy. You have to remove the thyroid before it develops malignancy. So this prophylactic thyroidectomy, Ghorlin, what is Ghorlin, Mehak? In MEN2A, this is done at 5 years of age. Ghrelin, if you are asking Ghrelin, it is a different thing. Ghorlin is, I don't know what is Ghorlin. In MEN2B, within 1 year, mostly 6 to 9 months. Within 6 to 9 months, you have to do the thyroidectomy. Okay. Recently, so these are the tumors, I mean, these are the syndromes, MEN1, MEN2, MEN2A is like 2A and 2B. 2B is also known as 3. Recently, they have come across a new thing, MEN4. MEN4 is also autosomal dominant. Actually, it looks like MEN1, but with a different gene mutation. Gene is CDKN1B gene, which is situated on chromosome 12. Okay, it is similar to a MEN-X syndrome in rats. So in these cases, the phenotypically means there will be, you can say, the pituitary tumors and parathyroid tumors. But when you do the gene mutation, it will not be MEN1 gene, it will be some other gene. Pituitary, parathyroids, then renal, adrenal, pancreas, other tumors may also be seen. Very few cases have been reported in the literature. Marfanoid habitus you will see in 2B. Okay, marfanoid habitus you will see in MEN2B. Okay, so these are all the important things which you are supposed to know in in men syndrome. Okay, so any question? Okay, so our question was about the tongue pay. There was this lesion. So this was mucosal neuroma. So which of the following tests will you perform? Hirschsprung can be seen in MEN2A. It is not seen in everybody. There are different varieties of MEN2. Okay, there are different varieties of MEN2. Classical MEN2, those tumors are seen, but Hirschsprung may be seen in MEN2A as well as MEN2B. So those are different sub-varieties of MEN2 syndrome. Forget about Hirschsprung, forget about Marfanoid habitus. People, they don't ask these things these days. They ask simple things. Okay, Hirschsprung may be seen in both the types. 2A, even in 2B you can see. Okay, so if you are suspecting because of this a MEN2B syndrome, so MEN2B syndrome, you have to check the vinyl mandelic acid because you are suspecting pheochromocytoma. Okay, insulin is in pancreatic tumor, gastrin in pancreatic. These are the tumors you might have to check if it is MEN1 syndrome. Okay, these are the pancreatic neuroendocrine tumor. And MEN1 syndrome, I mean these tumors you will not see in MEN2 syndrome. So in MEN2 syndrome you will see pheo. So that's why you will check for the pheo. Option A. A 2-year-old male presents with well-defined anterior neck mass located midline and above the cricoid cartilage. The mother reports no other medical history. It elevates when he swallows and it's non-tender. No cervical adenopathy. Which of the following is recommended before considering surgical excision? Okay, so this is a case where the child, 2-year-old child, is having a thyroid swelling. And in the midline thyroid swelling, he swallows and it elevates. This is very typical of thyroglossal cyst. Okay, so thyroglossal cyst, they are asking which of the following is recommended before considering surgical excision. You don't need to go for CT or MRI or FNAC, just a ultrasound is good enough. Okay, ultrasound is good enough because you want to make sure that it is, I mean, this thyroglossal cyst is not the only thyroid swelling present. You want to see the status of basically the normal thyroid gland. And for thyroid gland, for the lymph nodes in the neck, ultrasound is more than enough. CT, MRI kind of investigations are not required. Okay, so although this is a thyroglossal cyst, but you still want to know the status of the normal thyroid, and also to confirm that this is thyroglossal cyst, a ultrasound is good enough. A CT scan is not required. True regarding salivary gland tumor, we have already seen parotid are more likely to be malignant. That is incorrect. Submandibular are more likely to be malignant than minor. Minor is more malignant, so this is incorrect. Pleomorphic adenoma may undergo malignant degeneration. That is true statement. In 3 to 9% of the cases, that may go into malignant transformation. That is known as carcinoma ex pleomorphic adenoma. That is kind of high grade tumor. Warthin's tumor is benign. So only correct statement in this is C. And that is the answer. Femoral hernia in Nyhus classification. See, two classifications. I'll tell you three, in fact, in the hernia, which I think are important. Nyhus classification. One is indirect inguinal hernia through a snug deep inguinal ring. I mean the deep inguinal ring is tight, but still a hernia sac has managed to enter. Two is indirect inguinal hernia through a dilated deep inguinal ring. A dilated deep inguinal ring. Three is divided into different types. 3A is direct inguinal hernia, B is pantaloon hernia, and C is femoral hernia. And type 4 is when once you have done surgery and hernia has recurred, then it is type 4. Okay, so this is NIHS classification. These days, last year also there was this question. There is something known as European Hernia Society classification. European Hernia Society classification, first we'll see of like inguinal or groin hernias. In groin hernias, basically inguinal hernia and femoral hernia is there. So three things you need to see in European Hernia Society classification. The hernia can be either primary, that is happening for the first time, or recurrent, or the hernia can be lateral. Lateral, may you'll write L. So basically the indirect inguinal hernia is lateral because that comes laterally from the deep ring. It could be medial, you'll write M. Basically the direct inguinal hernia is medial, or it could be femoral, you'll write F. And third thing you will see in this is the defect size, the defect through which the hernial sac is coming. In the direct hernia, the defect is in the posterior wall of the inguinal canal. In the indirect hernia, the defect is in the deep ring through which the sac enters. So if the defect size is less than 1.5 centimeter, you'll write 1. If it is 1.5 to 3 centimeter, you'll write 2. And if it is more than 3 centimeter, you'll write 3. Like suppose it is written as RM3. It means it is a recurrent hernia, it is a direct hernia, and the defect in the posterior wall is more than 3 finger. PF1. Primary hernia, femoral hernia, the defect is less than 1.5 centimeter. Okay, so this is European Hernia Society classification. In one Faizan, this you are asking indirect inguinal hernia through a snug. Snug means tight deep inguinal ring. Okay, it was not dilated. In 2 it was dilated, in 1 it is not dilated. Means clinically when you examine that thing, you try to put your finger will not go in. Okay, in type 2, your 1 finger or maybe 2 fingers or sometimes even 3 finger, it can go in that defect. Okay, so this is NIHS and European Hernia Society classification of groin hernias. Now we'll see incisional hernia classification, and this question was asked last year. European Hernia Society classification of incisional hernia. Okay, suppose this is the abdomen. In the center there is this rectus muscle. This is xiphisternum, this is pubic symphysis, this is umbilicus. So incisional hernia is divided into midline and lateral incisional hernia. For midline, just see this thing from xiphisternum 3 centimeter below xiphisternum. Okay, I should write like this. 3 centimeter below xiphisternum, 3 centimeter above pubic symphysis, and 3 centimeter above and below umbilicus. Now you draw lines. So that divides this midline into 5 parts. This is M1, M2, M3, M4 and M5. M means midline. M1 is subxiphoid. M2 is epigastric. M3 is umbilical. M4 is infraumbilical and M5 is suprapubic. Okay, M1 to M5. Now in this part, see, suppose this is the anterior axillary line. Now you just extend this 3 centimeter above and below the umbilicus line to this part. So now it will become L1, L2, L3 and this is L4. So that is on the lateral side. On the right side, left side, both side it will be like this. L1 is subcostal, L2 is flank, L3 is iliac and L4 is lumbar. So this is M1 to M5 midline incisional hernia, L1 to L4 lateral incisional hernia, and the defect size in this is given as W1, W2 and W3, where W1 is when the defect is less than 4 centimeter, W2 is 4 to 10 centimeter and W3 is more than 10 centimeter. Okay, so these are the 3 important classifications which you need to remember in hernia: NIHS classification and European Hernia Society classification of groin hernia and European Hernia Society classification of incisional hernia. Okay. Is it clear? Any confusion, any doubt? So femoral hernia in NIHS is 3C. 11th question we have seen, according to Miami criteria, resection of parathyroid is adequate if there is drop in the parathyroid hormone should be less than half in 10 minutes. Less than half in 10 minutes, that is Miami. Match the hernia with the description. Richter's hernia is hernia containing the antemesenteric wall of the intestine. Triangle of doom you will see in case of laparoscopic hernia like TEP and TAPP. See, I'm sure you all know that when the appendix is found in the hernial sac, that hernia is known as Amyand's hernia. AMYANDS, Amyand's hernia. But if the appendix is seen in the femoral hernia sac, then it is known as D. Garangiode's hernia. D. Garangiode's hernia. And Speechlian hernia is hernia between the semilunar line and the rectus muscle. Okay, so this is the answer. Now, I guess A is the answer. A is the answer. Okay. Next question. Again, we have already done, so let's see. All of the following statements regarding the treatment of papillary thyroid are true except total thyroidectomy is indicated for cancer less more than 4 centimeter and for smaller cancers such as radiation, that is true. Reoperation is indicated for completion thyroidectomy who have papillary thyroid cancer with poorly differentiated after a hemithyroidectomy, that is true. If it is poorly differentiated, then we have to go for total. Prophylactic lateral neck dissection is indicated in most cases. This is incorrect. Okay, prophylactic neck dissection only in case of medullary thyroid cancer we are doing, not in papillary. After resection, exogenous thyroid should be titrated to achieve subnormal thyroid. So that we have seen. TSS suppression. So that is also true. The only incorrect option here is C. C. Complete surgical resection, that is thyroidectomy, is first line treatment of which of the following? I told you, whenever there is compressive symptom, only treatment you will do is surgery. So option number B. marked compressive symptoms. Don't have to see that this compression is because of malignancy or benign or whatever. If it is causing compression, you have to go for surgery. Okay, renal thyroiditis, the first line treatment here is steroids. There are other drugs, anti-proliferative drugs are also there, but first line is steroids. Acute suppurative thyroiditis, antibiotics, uncomplicated Graves' disease, the treatment we have already seen. Okay, like antithyroid drugs or radioiodine ablation. Which of the following technique is statement is true regarding the surgical technique of hernia? See, for the past 4 days, I guess 4-5 days, I'm having this severe cold and fever and all, so I might have to drink tea once or twice, maybe during the class also, so I apologize beforehand. But okay, to keep speaking, I need to have this, so we'll take a break after the initial 35 questions, and that time you people also can go and have tea. Bassini's repair can be used for femoral hernia. This is incorrect. Bassini repair is a type of herniorrhaphy which is used mainly for the inguinal hernia. The Schultes repair approximates the transversus abdominis to Cooper's ligament. See, this statement, which the statement B is saying, this whole statement is actually McVeigh's repair. And they are saying Schultes. In Schultes, mainly we do double breasting of the fascia transversalis and double breasting of the conjoint tendon with the inguinal ligament. Okay, so this statement is also incorrect. The whole statement tells about McVeigh's repair type of surgery. Break, Faizan, after the 35th question. Then there is only one break that will take later. A TP is a laparoscopic approach that stays in the preperitoneal space by using a balloon dissector. So this is correct. Total extraperitoneal repair is a laparoscopic approach where we will stay above the peritoneum and do the dissection in the preperitoneal space and put the mesh there. So this is the true statement. This is our answer. A Bassini repair uses a piece of mesh. Mesh is hernioplasty and Bassini is not hernioplasty. So C is the correct answer. In hernia topic particularly, you tell me if there is any particular thing which you want me to discuss, because hernia is a little bit vast topic and there are questions from hernia. So if there is anything which you find it difficult to understand, you let me know and I can discuss that particular thing. 47-year-old man undergoes resection and there is soft tissue deficit. You used to decide a myocutaneous flap for the reconstruction. So this is a flap from the pectoral area. The skin and the muscle subcutaneous tissue is mobilized and used to repair the defect in this side. This flap is pectoralis major myocutaneous flap. All the flaps we know are based on some type of blood supply. So this is based on pectoral branch of thoracoacromial artery. Pectoral branch of thoracoacromial artery. So D is the answer. Okay, hernia repair in brief. Okay, so see, for hernia, the treatment is surgery. Okay, either you do surgery or you don't do anything. It's not necessary that you go for surgery in all the cases. Either surgery or don't do anything. So treatment is surgery. Surgery can be done in two ways. One is open repair and one is laparoscopic repair. First we'll see open repair and then we'll see laparoscopic. Both are good, but laparoscopic is preferred. In which case laparoscopic is preferred? In case of females, in case of bilateral hernia, in case of recurrent hernia. So in these cases, lap is more preferred over open. Laparoscopic is done always under general anesthesia. Open can be done in general anesthesia, spinal anesthesia, or even local anesthesia. Now I'll tell you. See, in open surgery, what we do is patient is lying on the OT table. Okay, so you do painting and draping. Then you give the incision 1 centimeter, 1 finger breadth above the inguinal ligament. You give the incision. You'll cut the skin. You'll cut the subcutaneous tissue, and then you'll find the external oblique aponeurosis, very shiny structure. So that is the anterior wall of the inguinal canal. Okay, so you'll cut the external oblique aponeurosis. Now inside the inguinal canal there is cord structure is going and hernia sac is also going. You'll put your finger and lift whatever part is in the inguinal canal. So now in your finger there is hernia sac and the normal cord structures like vas and the gonadal vessel, other things. So you'll separate the sac from the cord structures. Leave the cord structure behind. Now in your hand there is sac. Okay, palpate the sac. There should not be any content. Open the sac, identify if there is anything, put it back. Now you ligate the sac at the deep inguinal ring and cut the sac. Okay, so finding the sac, separating from the cord structure, opening and dividing the sac, this much is known as herniotomy. Okay, if we have done this much, that is known as herniotomy. Now hernia is very notorious for the recurrence. So after the herniotomy, there are chances that the hernia can occur again. So after the herniotomy, you need to do the strengthening of posterior wall of inguinal canal. So strengthening of posterior wall of inguinal canal can be done in two ways. One is you use the local tissues and the suture to strengthen the posterior wall. Posterior wall of the inguinal canal is basically fascia transversalis. So if you are using sutures and local tissues surrounding it to strengthen the posterior wall, then it is known as herniorrhaphy. And for strengthening of the posterior inguinal canal, if you are putting a mesh, then it is hernioplasty. Okay, so after doing a herniotomy, you have to do either a herniorrhaphy or a hernioplasty. Now in case of pediatric age group, you do only herniotomy, you don't do herniorrhaphy or hernioplasty because anyways they are going to grow in size, and if you put a mesh, that will cause fibrosis and asymmetrical growth in that area. So herniotomy alone is the treatment of choice in congenital hernia or congenital hydrocele. In case of adults, after doing a herniotomy, you have to do either a herniorrhaphy or a hernioplasty. Okay, now there are different types of herniorrhaphies like Bassini's repair. In Bassini's repair, you will just do the suturing between the conjoint tendon and the inguinal ligament. Shoulder's repair is a surgery where you will do double breasting of the fascia transversalis. Fascia transversalis is like this. You will cut and do something like this, and the same double breasting of conjoint tendon with the inguinal ligament. So that is a multi-layered repair. Multi-layered. Then there is McVeigh's repair, and there is Desarda repair. In Desarda repair, basically external oblique aponeurosis is used. McVeigh's repair is option number B, where I told you. Hernioplasty is more preferred because this does not cause the tissue to go under tension because you are only putting a mesh. Example, Lichtenstein tension-free meshplasty. Lichtenstein tension-free meshplasty. Patch and plug repair. There is something known as Prolene hernia system. Prolene hernia system. And one more repair where you use the mesh in a preperitoneal space, that is Topaz repair. Okay, so these are the open surgeries: herniorrhaphy, hernioplasty, okay, herniorrhaphy, herniotomy. These are the open repairs. So see, laparoscopic, suppose this is the abdominal cavity. Let's try to understand. This is the abdominal cavity. In the abdominal cavity, suppose this is the peritoneal cavity. This is the peritoneum. This is the head end. This is the foot end of the patient. Okay, so suppose this layer is fascia transversalis. Fascia transversalis is the layer just below the muscle, that is transversalis abdominis muscle. Okay, so in the open surgery, we come and do the repair here. In the open surgery, we come and do the repair and put the mesh in this layer, just above the fascia transversalis. In the laparoscopic surgery, when they said that in laparoscopic surgery will come from the posterior approach. One approach is you go inside the abdomen, come to this part, cut the peritoneum and go in this area and do the surgery, put the mesh. So this surgery where you are coming into the abdominal cavity, that is known as TAPP, transabdominal preperitoneal repair. Okay, transabdominal preperitoneal repair. Another surgery, as the people becoming more confident in this surgery, they say that if you want to go in the preperitoneal area, then why do you have to go through the abdominal cavity and cut the peritoneum and go in this area? Why can't you make a space between the abdominal wall and the peritoneum and go in this area from the beginning? So that surgery is known as TEP, total extraperitoneal repair. Extra means outside, peritoneum is peritoneum, total extraperitoneal repair. So this TAPP and TP are the laparoscopic hernia repair. Okay, these are the laparoscopic hernia repair. So when people started doing these surgeries, just imagine that what kind of appearance they will get. Suppose you are sitting inside the abdominal cavity and looking at this area. This is what the surgeon will see when he operates in this area. Okay, so I'll tell you, suppose this is from inside. From inside, he will see two deep inguinal rings. Okay, two deep inguinal rings. There are certain ligaments, median umbilical ligament, medial lateral umbilical ligament. These things I'm not going very deep into this. And there will be a layer of the peritoneum which is covering the whole of the anterior abdominal wall from inside. So first when you start surgery, you cut the peritoneum and go in the preperitoneal space. So when you go in the preperitoneal space, suppose this is the deep ring, and now you have opened the peritoneum like this. Rest everywhere is the peritoneum. You have just opened the peritoneum around that deep ring, and now you enter into the preperitoneal space. So this is the preperitoneal space where you have entered. Now here from one side you will see that the vas is entering in the deep ring. From other side you will see that the gonadal vessel is entering in the vas. This part is nothing but the peritoneum only. Peritoneum. So this forms a triangle here which is known as triangle of doom. Okay, so this is known as triangle of doom, where vas is present medially, gonadal vessel is present laterally, and inferiorly there is peritoneum. Importance of this triangle of doom is that the external iliac vessel runs in this triangle. So when you are doing surgery, when you are doing dissection, you have to be very, very careful in this area. Otherwise, you might injure a very important vessel, that is external iliac vessel. Just lateral to this triangle, see this is the area from where the iliopubic tract goes. Iliopubic tract is a thick fibers which are running under the inguinal ligament, iliopubic tract. So iliopubic tract present superiorly, gonadal vessel present laterally, and this peritoneum present, gonadal vessel present medially, peritoneum present laterally. This is nothing but peritoneum. So this forms another triangle. This is known as triangle of pain. Why it is known as triangle of pain? Because in this area many nerves are going. Nerves like femoral nerve, femoral branch of genitofemoral nerve, anterior cutaneous nerve of thigh, lateral cutaneous nerve of thigh. So the problem is when you are doing the surgery and suppose you want to put mesh in this area. In laparoscopic surgery also you need to put a mesh in this area. So when you are putting mesh, you need to fix the mesh by a certain mesh fixation device. Those are known as tackers. Okay, so usually we put the tackers in these area. These are safe area to put the tackers. These are mesh fixation device. Important is if your tacker comes in this triangle of pain, then it will go and it will hit one of the nerve and the patient will have pain in the post-operative period. Okay, so in these two areas, no tacker should come. Okay, these are the two important areas, triangle of doom and pain. Here you should not put any mesh fixation device because in doom there is a major vessel, in pain there are important nerves, so it should not be done. Usually the first tacker which you put is placed in a very nice bony structure is seen, that is known as Cooper's ligament. Cooper's ligament is seen in laparoscopic surgery, a white structure. During surgery we call it as lighthouse sign or White House sign. So usually Cooper's ligament is a bony structure, very safe to put a tacker. Sometimes a abnormal blood vessel from inferior epigastric artery goes and meets with the obturator artery. So this is known as aberrant obturator artery. So if this aberrant obturator artery is present and you don't identify this and you put a tacker on this, it will start bleeding and this bleeding is difficult to stop. So this aberrant obturator artery running in front of Cooper's ligament is known as corona mortis. Corona mortis. So one should be very careful to find out this corona mortis. In few cases, 1 to 2% of cases, this may be seen. Okay, so this is triangle of doom, this is triangle of pain, this is corona mortis, these things. What is TAPP? What is TEPP? That is laparoscopic hernia repair. Open hernia is herniotomy and then herniorrhaphy or hernioplasty. After doing herniotmy, you can do either a plasty or a rhaphy. Plasty is more preferred because the tissues are not under tension. Inferior epigastric artery, it is IEA, inferior epigastric artery to the obturator artery. Usually nothing is going as a connection. If aberrant obturator artery is going, that is known as corona mortis. I hope you have understood a little bit about the treatment, what is done in laparoscopic hernia and what is done in open hernia repair. Okay, coming back to our paper, pectoral branch of thoracoacromial artery is this PMMC flap. Which of the following hernia is most likely to recur after a primary repair? It is incisional hernia. The maximum chances of recurrence is in incisional hernia. Femoral hernia has maximum risk of strangulation. Maximum risk of strangulation. Commonly injured nerve, Shrey, you are asking in open hernia or in case of laparoscopic hernia. Laparoscopic hernia, usually the nerve injury is not common. In the open hernia, iliohypogastric nerve is most commonly injured, iliohypogastric or ilioinguinal nerve. Maximum risk of strangulation in femoral hernia. and most common to recur is incisional hernia. Match the following. We have seen Samoma bodies in papillary thyroid, amyloid in medullary thyroid, HLA-B35 you will see in decurvence. Hashimoto thyroiditis is a risk factor for non-Hodgkin's lymphoma. So whatever is the answer, what is the answer? A. 40-year-old male, see, male smoker, bilateral swelling. So these are the important things you will see in which tumor is having, which salivary gland tumor is having chances of bilateral involvement, and more common in males, Warthin's tumor. Okay, Warthin's tumor, which is also known as adenolymphoma and also known as papillary cystadenoma lymphomatosum. So that is another name for Warthin's tumor. Bilateral, more common in males, smokers, benign Warthin's or adenolymphoma. Patient with tongue cancer has a tumor of 4 cm on the right lateral border. So this is about the TNM staging of oral cancer. Oral cavity cancer is important TNM staging. There are many TNM stagings which are important. The most important being the breast cancer. This is also very important TNM. And then other stagings we'll see in urology. There are certain stagings important like in prostate and in kidney. So that we'll see in the urology part. But first we'll see in this the TNM staging. TNM staging of oral cavity cancer. Okay, now see, this staging is a little bit difficult to remember. So first I'll tell you what was the TNM staging in the 7th edition. Now though there is 8th edition, AJCC is going on. But first I'll tell you what was the staging in 7th edition, and then I'll tell you what are the changes they have made in the 8th edition. So as per the 7th edition, it was very easy. T1 was less than equal to 2 cm. T2 is more than 2 to 4 cm. T3 was more than 4 cm tumor. Then T4A was involvement of skin, maxilla, mandible, and B was involvement of base of skull or carotid vessels. So this was very straightforward T staging in as per the 7th edition. In 8th edition, what they said was that it is not only the size of the tumor, but the depth of invasion is also very important. So they have introduced something known as depth of invasion. Means how deep the tumor is going from the mucosal surface, that is depth of invasion. Okay, so after introducing depth of invasion, the staging becomes a little bit complicated. Now how will you remember? T1 is less than 2 cm with depth of invasion less than 5 mm. T2 is more than 2 to 4 with depth of invasion less than 10 mm. And T3 is more than 4 with depth of invasion less than 10 mm. This much you can remember. Okay, so initially 2 to 4, more than 4, and something that is T4. Then you add depth of invasion less than 5, less than 10, less than 10. Now you will see this is T1. T1 is this. T2 is this, but one more thing comes in T2. How will you remember? Just bring this thing down by increasing the depth. So less than equal to 2 cm with depth of invasion more than 5 mm to 10 mm. So now this one and this one both are T2. T3 is this, and one more thing, just bring this thing down with increasing the depth. More than 2 to 4 centimeter with depth of invasion more than 10 mm. Now this one is also T3 and this one is also T3. T4A is this, along with this also comes as T4A, more than 4 centimeter with depth of invasion more than 10 mm. So this is also T4A and this is also T4A. T4B, there is no change, no update, so that is T4B. Okay, so now you can see how the staging becomes complicated when you introduce depth of invasion. So if you find it very difficult, at least remember this thing. If depth of invasion part is difficult, at least remember what I had written with the green thing. Okay, N staging. N0 is no lymph node involvement. N1 is single ipsilateral lymph node which is less than equal to 3 centimeter. Single same site less than equal to 3 centimeter. N2A is single ipsilateral lymph node more than 3 up to 6 centimeter. P is multiple ipsilateral, multiple lymph nodes on the same side. Same side means suppose right side tongue cancer and right side lymph node. None of these should be more than 6 centimeter. N2C is bilateral or contralateral, but none of these should be more than 6 centimeter. And N3 was more than 6 centimeter. Now in the 8th edition they have done just one change. They said that all these are ENE negative. ENE means extra nodal extent. Means the tumor is there in the node but it is not going outside the lymph node. So that is extra nodal extent is negative. And they have introduced, they call this as N3A, and they have introduced a new category N3B, that is any lymph node with extra nodal extent positive. So that is the N stage. And M0, M1 is M0, M1 like any other tumor, no distant metastasis. And M1 is when there is distant metastasis. Now I'll tell you a very basic thing, like if it is T1 N0 M0, T2 N0 M0, T1 N0 M0 is stage 1, T2 N0 M0 is stage 2, T3 N0 M0 or T1 to 3 anything N1 M0, that is stage 3. Stage 4 is if there is any T4, if there is any N2, if there is any N3, if there is any M1, that is stage 4. Okay, so oral cavity cancers or head and neck cancers are mostly squamous cell cancers. And squamous cell cancers in general, if we see a rule, squamous cell cancers are either treated by surgery or radiotherapy. Adenocarcinomas are treated by surgery or chemo. Okay, it is a general rule. So in stage 1 or 2, you can either do surgery or you can go for radiotherapy. Either surgery or radiotherapy. In stage 3 and 4, you have to do surgery and you need to give radiotherapy and you need to give chemo also. So in stage 3 and 4, multimodality treatment. In stage 1 or 2, single modality treatment. Okay, be it a lip cancer or cheek cancer or tongue cancer, this is in general the treatment guidelines of oral cavity cancers. Okay, now we'll go back to the question. I know the staging is a bit difficult. Okay, so 4 centimeter tumor. more than 2 to 4, so this is T2. Right lateral border, depth of invasion 7 mm. Okay, so 2 to 4 centimeter, depth of invasion less than 10 mm, so it will be T2. Single mobile ipsilateral lymph node measuring 6 centimeter without extranodal extension. Single mobile means N2A. Up to 6 centimeter will be N2A. If it is more than 6 centimeter, then it would have been N3A. So T2, N2A, M0 is the staging. So B is the answer. T2, N2, M0. I know this is more of a difficult type of staging, but somehow this is important. So that's why I told you, if DOI, depth of invasion part, you find it difficult, then you can omit that thing. At least remember 2 or up to 2 centimeter is T1, more than 2 to 4 centimeter is T2, more than 4 centimeter is T3, T4A is skin, maxilla and mandible, and T4B is base of skull and carotid vessel. Yes, Aditi, it is T2, yes. Which of the following is true regarding the characteristic of mesh used in hernia repair? Lightweight mesh के बारे में just see. Lightweight mesh is, the weight of lightweight mesh is less than 40 gram per meter square and the pore size is 3 to 4 mm. Heavyweight mesh, on the other hand, it is like this. Weight is more than 80 gram per meter square and the pore size is 1 millimeter. So lightweight mesh is preferred in groin hernia surgery and heavyweight mesh is preferred in incisional hernia. This is for groin hernia. Inguinal hernia and all, this is preferred. Medium weight or heavy weight is preferred in incisional hernia. So lightweight mesh produces less intense inflammatory reaction. So this statement is wrong. Biological meshes, the advantage is it can be placed into a contaminated field. So this statement is also wrong. The only advantage of biological mesh is, biological mesh you can get from the like dermis of the cadaver or intestinal submucosa of the pig or serosa of the cattle. So you remove the cells part and just the collagen part is used to make the mesh. The advantage of biological mesh is it can be placed at the contaminated area. Otherwise, those artificial meshes you cannot place at the contaminated area. It can lead to severe, post-surgery infection. Biological mesh are although more costly. Polypropylene mesh have high adhesion risk, so they should not be placed directly next to the bowel. That is a true statement. Okay, the meshes are having property of adhesions and intestine can come and stick to this and can lead to obstruction, perforation, so it should not be placed directly in contact with the intestine. If you have to place, then you use a different type of mesh that is known as composite mesh. Composite mesh mein there will be a layer of oxidized regenerated cellulose or collagen layer, so that will prevent this adhesion. Biological meshes are processed human, bovine and porcine tissue composed of collagen matrix. See, up to this part, up to this matrix, the statement is correct, and immune cells make this incorrect statement because it does not have any cells. It has just the collagen part which is used for the mesh formation. So the only correct option here is C. C. 36-year-old female presents with palpitation, anxiety, hypertension. Workup reveals FEO. Which of the following is best approach to optimize the patient preoperatively? Fluid restriction is not required. Initiation of alpha blocker. 24 hours prior is not going to help. You have to start at least 1 to 3 weeks prior to the surgery. Initiation of beta blocker. After the completion of the alpha blockade, you give beta blockers. So option number C is the correct answer. And the alpha blocker which we use is phenoxybenzamine. Pheochromocytoma again is an important topic. that again I'll discuss. Pheochromocytoma. Every year they ask question on this. Pheochromocytoma. See, I'm sure you must have read about this many times. Can you tell me the meaning of this? Okay, pheo means brown, chromo means color, cyto means cell, oma is tumor. Brown color cell producing tumor. So, although not important, but still, that is the meaning of pheochromocytoma. So, a tumor arising from the adrenal medulla or chromaffin cells elsewhere in the body, that is pheochromocytoma. Mostly a benign tumor. There is something known as 10% rule. In 10% of the cases, it can be malignant. 10% of the time, it can be multiple. 10% of the time, it can be bilateral. 10% of the time, it can be seen in children. 10% of the time, extra-adrenal. Most common symptom associated with pheochromocytoma is hypertension. 10% of the time, not associated with hypertension, means 90% of the time there will be hypertension. Suppose this is the aorta, abdominal aorta. Here it bifurcates into two common iliac artery. So there are chromaffin cells present at the aortic bifurcation. These are known as organ of Zuckerkandl. These are the chromaffin cells, and the most common site of extra-adrenal pheo is this organ of Zuckerkandl. Okay, so pheochromocytoma is a tumor which produces excessive catecholamines. 25% of the time it is familial, means associated with some syndromes. So what are the syndromes associated? We have seen one MEN2A and 2B syndrome, von Hippel-Lindau syndrome, neurofibromatosis 1 syndrome, and familial paraganglioma syndrome. Familial paraganglioma syndrome. Now see, normal adrenal gland will produce adrenaline more than noradrenaline. Pheochromocytoma produce noradrenaline more than adrenaline. If it is a extra adrenal pheo, then it will produce only noradrenaline. If it is a pheo associated with men, it will produce only adrenaline. And if it is a malignant pheo, it will produce only dopamine. Okay, so another important thing, investigation. If you are suspecting that this is a pheochromocytoma, the first thing is you need to make sure that whether it is pheo or not pheo. So for that you go for biochemical investigation. In biochemical, pheochromocytoma produces excessive catecholamines. So if you see the urine or the serum, you will find the byproducts of these catecholamines, that is metanephrines and vinyl mandelic acid. So now you tell me whether these things you will check in urine or you will check in plasma. Where will you check this metanephrines or VMA? Okay, so I'll tell you, urinary metanephrines or VMA you will check in low risk patient, and plasma you will check in high risk patient. So what is low risk and high risk? High risk means if the patient belongs to any of those syndromes. If the patient is having a family history of pheochromocytoma, if the patient is having personal history of pheochromocytoma, suppose the patient has developed pheochromocytoma of right adrenal 5 years back, now there is some suspicion of pheochromocytoma in the left adrenal, go for plasma, VMA or metanephrine, not urine. So if these things are not there, then it is urinary, you will check. If these things, any of these things are there, you will check plasma. Okay, so remember this thing, because most of the people, they believe that in all the cases you will go for urinary. Once there was a question that a patient of VHL syndrome comes and you are suspecting pheochromocytoma, what investigation you will send? So patient belongs to syndrome, you will prefer plasma metanephrine or VMA, not urine. Okay, Faizan, remember this important difference. Now, radiological. Radiological, you want to know that whether this pheochromocytoma is present in the right adrenal or left adrenal, and if not in adrenal, then where else it is present. So first you will go for CT or MRI. Okay, first you will go for CT. If not localized, then you will go for MRI. Okay, if you can localize on CT, you don't have to go for MRI. MRI is overall the investigation of choice. Suppose it is not localized on MRI also, then you go for a nuclear scan, which is known as MIBG, meta-ido-benzyl guanidine scan. So this is how you do the localization. For malignant pheo, you go for something known as DOPA PET, and these days there is a new gallium dotatate scan. Okay, so this is how you localize. Treatment, first you will do pre-op preparation, alpha blocker, that is phenoxybenzamine. Usually mostly people they give 3 weeks, but chalo, as per the books, 1 to 3 weeks prior to surgery. And then after the alpha blockade is complete, give beta blocker, and then you go for surgery. These days mostly we go for laparoscopic adrenalectomy. Okay, so these are the important things about pheochromocytoma. Okay, so next thing we will see. Next question. Question number 23. All of the following are high risk lesion for developing oral carcinoma except erythroplakia is high risk, proliferative varicose leukoplakia is high risk, chronic hyperplastic candidiasis is high risk. This is low risk. This is the answer. MIBG is meta-ido-benzyl guanidine. Okay, Karuna Sri, meta-ido-benzyl guanidine scan. Okay, so just one thing I'll tell you. In this high risk potentially malignant disorder for the oral cancer is leukoplakia, that is a white patch on the oral cavity. Erythroplakia, that is a red patch. And chronic hyperplastic candidiasis. In leukoplakia, one is homogeneous type and one is heterogeneous type. In heterogeneous, there is speckled or verrucous leukoplakia. Now just one thing. FDG PET is not done in pheo puja. FDG PET is not required. Now you tell me, among these, all these are high risk, which is having the maximum risk of turning into malignancy? Which has the maximum risk of malignancy? Which has the maximum risk? Maximum risk of turning into malignancy. See, recently this question has been asked also, and the guidelines are also changed. Speckled or verrucous type of leukoplakia has the maximum risk. Okay, previously, yes, erythroplakia, people used to mark erythroplakia, but now if the question comes and you have speckled or verrucous type of leukoplakia, that has the maximum risk. Okay, heterogeneous leuko. Okay, Sakshi. Maximum risk is heterogeneous type of leukoplakia. At which age the following defect should be repaired? So this child is having a cleft lip as well as a complete cleft palate. Okay, so if there is only cleft lip, then this should be repaired at the age of 5 to 6 months. If there is cleft palate, and in cleft palate only the soft palate, then 6 months. And if there is soft plus hard palate, then you have to do surgery in 2 phases. At 6 months you repair the soft palate, and at 15 to 18 months you repair the hard palate. Okay, this is Faizan. It was just I was telling leukoplakia. This is the flow chart you are asking, or the pheochromocytoma wala flow chart you are asking? And if there is cleft lip as well as palate, okay Faizan, just specify which flow chart you want me to show you again. I'll show, not a problem. Then again at 6 months you will repair lip and soft palate like in this image, and at 15 to 18 months you will repair hard palate. Okay, so this is important for the, in cleft lip mainly they will ask you the timing of surgery. So this is the timing of surgery. This is the timing of surgery. Okay, should I go to the next question? So this is complete. So 2 stages at 6 months and 15 to 18 months. MASIS is a prognostic score for the differentiated thyroid cancer. There are prognostic scores like AGIS, AMIS and MASIS. Okay, where A stands for age, G is grade, S is size, E is extrathyroidal extent. Extrathyroidal extent. A is age, E is extrathyroidal, S is size, M is metastasis. M is metastasis, age, size, C is completeness of surgery, and I is invasiveness. Okay, so activity of tumor is not a part of any of these scores. Age is AMIS, MASIS, these are the prognostic scores that in case of papillary and follicular or Husserl cell carcinoma, after doing the surgery, based on these things, we'll say that which patient comes under low risk and high risk. And in low risk cases, most of the time the 20-year survival is more than 90%. Okay, so these are the prognostic criteria in differentiated thyroid cancers. Next question, 45-year-old female with a hypertension, facial hair and a 7 centimeter suprarenal mass. So patient is having symptoms, hypertension, facial hair and a 7 centimeter suprarenal mass. So all these are going in favor of Cushing's. But it is not Cushing's disease, it is Cushing tumor, and mostly the adrenocortical carcinoma present as Cushing. Adrenocortical carcinoma 50% of the time presents as non-functional. 30% of the time it presents as Cushing's. 20% of the time it presents as virilizing or feminizing tumor. and just 2% of the time it can present as Conn's tumor. Completeness of surgery. Okay, completeness of surgery. So most common, you can say the functional presentation of adrenocortical carcinoma is Cushing's. Otherwise, mostly it presents as non-functional. Next question, 38-year-old singer who underwent total thyroidectomy and reduction in her pitch. So we have seen this is superior laryngeal nerve, which is another name for external laryngeal nerve. Okay, loss of pitch or tone. This question is, there was something in the thyroid. Okay, I'm not going to read the whole thing. And FNA shows this picture. And you can see this kind of picture. I have just shown you something like this. This is amyloid stroma. Amyloid stroma on FNAC is medullary thyroid cancer. And what treatment we do medullary thyroid cancer? Total thyroidectomy and central neck dissection we have to do in all the cases. In 26, why not be 26? Cushing disease is different. Cushing disease is when there is problem here, pituitary pe, when there is increase in the ACTH. Okay, there is something on the suprarenal, there is a tumor in the adrenal. So that's why it is adrenocortical carcinoma. If the option here is Cushing's tumor or Cushing's adenoma, then the answer would have been correct. But Cushing disease is when the pituitary produces excessive ACTH, that is Cushing disease. Okay, Mehak. Okay, so D is the answer. Question 27 is reduction in her pitch. So we have seen in the beginning of the class only in the complication that external laryngeal nerve injury causes loss of pitch or tone. The patient will not be able to speak or sing on high notes. So that's why answer is superior laryngeal or external laryngeal nerve. Okay, Faizan. 28 is, we have seen it is medullary thyroid cancer, and I told you in all the cases you have to go for level 6 lymph node removal. Which of the following is true statement regarding parathyroid carcinoma? If a neck mass is palpable, parathyroid carcinoma should be suspected. This is true statement. Reported overall 5-year survival rate is not 30%, it is like 50 to 70%. Okay, so it is not that bad a tumor. Serum calcium I told you is mostly more than 14. So correct answer is A. Normally the parathyroids are not palpable. If it is palpable, one should think about that they probably are dealing with a malignancy. Thirty 56-year-old female and left-sided facial swelling. Patient has weakness. Biopsy shows a high-grade mucoepidermoid carcinoma. There are no palpable lymph nodes. What is the best treatment in these cases? Surgery followed by radiation. Okay, we'll see. See, if the patient is having high-grade tumor. Okay, salivary gland tumor, if there is high-grade tumor, if there are positive margins, if there is deep lobe involvement, or if there is adenoid cystic carcinoma. These are the cases where you will give radiotherapy. Otherwise, radiation is not usually given in the salivary gland tumors. High grade, positive margin, deep lobe involvement, and adenoid cystic carcinoma are some of the indications where radiotherapy is given. This is again by cleft lip and palate. Cleft lip is uncommon. It is cleft lip or cleft palate anomaly is seen in 1 in 500 live birth, not 5,000. The repair of cleft lip, I told you 5 to 6 months, not 9 months. Structure anterior to the, there is a line known as incisive foramen, that is known as primary palate. Okay, primary palate is anterior to incisive foramen. With the soft palate cleft, the palatal musculature is abnormally inserted onto the posterior margin of the hard palate. That is true statement. If there is cleft of the soft palate, the muscle is abnormally inserted into the hard palate. That is the true statement. That is our answer. D is the answer. Don't have to go in very detail of the anatomy of that palate, but yes, the basic things you should know. Okay. Next question is 32. A patient being worked up for pain abdomen found to have gallstones with the thickened gallbladder wall, means there is acute cholecystitis. CT was done to rule out malignancy and a left adrenal lesion was also found. So what is this lesion? What is this diagnosis? That the CT was done for something else, but you found something on the adrenal gland. So this is known as incidentaloma. Incidentaloma can be a non-functional adenoma or it could be a functional tumor. Functional tumor like any of those Conn's adenoma, Cushing's adenoma, pheochromocytoma, adrenocortical carcinoma, anything which is producing something and that something is causing some symptoms. So if it is functional tumor, you have to do surgery. Non-functional adenoma means there is a tumor on the adrenal, but that is not producing anything which will lead to any symptom. So that is non-functional. So the question is, yes, very good, Aditi. What is the indication for surgery in a non-functional adenoma? Non-functional adenoma. If the size is more than 6 centimeter. Okay. Suppose size 4 to 6 centimeter. In these cases, if there is suspicious imaging finding, like if it looks heterogeneous, okay, heterogeneous means it will not appear same at all the areas, or if there is irregular margin. So if it is more than 6 centimeter, you don't have to think, just take it out. If it is between 4 to 6 centimeter, then any of these findings you will take it out. And if it is size less than 4 centimeter, you remove if the rate of growth is more than 20% in a year. If every year it is increasing by more than 20%, then you remove it. Okay, so basically these things will suggest that this could be malignant. This non-functional adenoma could be malignant if any of these things are there. More than 6 centimeter, heterogeneous, irregular margin, rate of growth is more than 20%, means this could be malignant. Okay. Just 10 more minutes, we'll take a break. So here answer is all of the above. Size less than 4 centimeter, rate of growth more than 20% in a year is indication for surgery. Okay, Faizan. Which of the following statement regarding carotid body tumor is false? See, suppose this is carotid artery, common carotid artery, which divides into internal carotid artery and external carotid artery. So at the bifurcation, there is a chemoreceptor present, which is known as carotid body. And if there is enlargement of this carotid body occurs, that is known as carotid body tumor. Okay, now the exact cause of this is not known, but mostly it is a benign tumor, firm, kind of pulsatile, with side to side mobility is present, but vertical mobility is absent. This is very important. They give this in the exam. A benign tumor, firm, pulsatile. Because it is vascular, so investigation of choice is usually a Doppler FNAC or biopsy should not be done. That will lead to more damage and bleeding. FNAC or biopsy is not done. If you do angiography, if not surgery, then what is the treatment, Shrey? Then you will do follow-up. Okay, every 6 months you'll call the patient, get the CT or MRI done to see that whether any of these changes are there or not. Okay, that is follow-up. You call the patient. Suppose I find the patient in January, then I'll tell, okay, go back home. Suppose the size is less than 4 centimeter, everything is fine. I'll ask him to come after 6 months or come after 1 year, and then I'll see that in this 1 year what is the change in size, whether it is same or increasing or decreasing. If increasing, how much increasing, and whether any heterogeneous feature or irregular wall has developed or not. So many times the patient, the size remains same, stable, so you keep on just watching the patient and you might not have to do surgery ever in these cases. Okay, if you do angiography, you will see that the angle between the internal carotid and external carotid increases because of this tumor. So that is known as Lyer's sign. Lyer's sign. Now see, suppose these are the vessels, external and internal carotid. Suppose that tumor is not encasing any of the vessel, then it is known as Chamberlain 1. Suppose it is encasing partially, that is Chamberlain 2, partial encasement of vessel. And if it is causing complete encasement of vessel, that is Chamberlain 3. So treatment is, in these cases, you have to remove the tumor completely, especially in case of younger individuals. In the elderly patient, you can wait and watch. But in a younger patient, you need to take it out. Chamberlain 1 and 2, you can remove it without, disturbing the vessel. But in Chamberlain 3, most of the time, vascular reconstruction is required. Okay, so these are the important things about carotid body tumor. So most of the tumors are benign in nature, that is true. In Chamberlain 1, most cases vascular reconstruction is required, that is incorrect. Mostly vascular reconstruction is required in Chamberlain 3. Chamberlain 1, you can remove it easily. Lyer's sign may be seen, side to side mobility is seen. The only incorrect option is B, that is our answer. 23-year-old patient, headache, hypertension, flushing, very classical of pheochromocytoma. It is also shown on a mass rising from the left-sided adrenal. So not true about this condition. MRI is investigation of choice, true. Pre-op preparation is required, true. Mostly benign is true. Li-Fraumeni syndrome is important risk factor. We have seen the syndrome associated with Pheo, and Li-Fraumeni was not there, so this is the answer. Li-Fraumeni syndrome actually is a risk factor for adrenocortical carcinoma. For adrenocortical carcinoma, Li-Fraumeni is a risk factor, not for pheochromocytoma. Okay, this diagram, Faizan, or this diagram. Okay, next question. 45-year-old female, newly diagnosed, and posterior pharyngeal mass MRI shows these things. This is the tongue, and just posterior to the tongue you can see a thyroid-like thing. So this is very classical of lingual thyroid. So next step in the appropriate management, no need of CT, FNA, you have to go for radioiodine scan. I hope this question all of you have done correct. We all know that in lingual thyroid, first you do a radioiodine scan to see the other ectopic thyroid tissues in the body, and then you'll decide the type of treatment required. Okay, so radioiodine scan is done. Patient presents in the lesion. So there is carcinoma lip, and carcinoma lip mostly goes to level 1 group of lymph nodes. Okay, submental, submandibular, level 1. Next question, 49-year-old man who underwent liver transplant 5 years back for alcoholic cirrhosis, and there is gradually increasing bilirubin level. He undergoes liver biopsy which demonstrate paucity of the bile ducts. Paucity of the bile duct is also known as vanishing bile duct syndrome, and this indicates that there is rejection. Question 33 is 32, 33 is B. B is the incorrect. Just 2 more questions and then we'll take break. Vanishing bile duct syndrome is rejection. So in these cases, which demonstrates paucity of bile duct. Now see, if this rejection, there are 3 types of rejection. Let me tell you this. One is hyperacute rejection that occurs within hours of transplant, and usually it is due to pre-formed antibodies, and it is irreversible. Another type of rejection is acute, that is within first 6 months, usually cell mediated, T cell, B cell mediated. This is the most common type of rejection and usually reversible. So for acute rejection, you can increase the immunosuppression, the organ will survive. Third is chronic rejection, that is after 6 months up to years, any rejection is chronic. So usually this is antibody mediated. It will cause fibrosis in the graft and again irreversible. So in irreversible type of rejections, you have to remove the organ and do the retransplantation. In this question, the patient underwent surgery 5 years back. So this is a chronic type of rejection, and that's why you have to go for retransplantation. 35, the answer is D. Okay, Sajal, it is D because in ectopic or lingual thyroid, you will go for radioiodine scan first. Okay, so retransplantation. A hypertensive 47-year-old man and proposed for kidney transplant. Which of the following would preclude renal transplant? Preclude means which will be contraindication to the transplant. Positive cross match is the answer, because positive cross match tells that there is pre-formed antibodies in the recipient. So if there are pre-formed antibodies, that can lead to hyperacute type of rejection, and if there is positive cross match, you don't do transplantation. Okay, transplantation is not done if there is pre-formed antibodies. This slide, Deepika, hyperacute, acute and chronic. Okay, so only type of reversible is acute. In these cases, you need to go for retransplant. In this case, you can increase the immunosuppression. 38. See, hyperacute rejection. Preformed antibodies. Preformed antibodies are antibodies because of prior blood transfusion or prior transplant. Okay, like let me take you one example. There is a patient A. He is a recipient. He needs kidney transplant. Now the donor is the elder brother. This elder brother, he gives history that he has given blood transfusion to this patient 2 years back. So at the time of blood transfusion, now the recipient body is having a antibody already. So now he is giving kidney to the brother. So if you don't do this cross match will check this preformed antibodies. Okay, this is preformed. Now when he is giving this kidney to his younger brother, now recipient already has its preformed antibodies. Now when the kidney comes, these antibodies will go and it will cause damage of that kidney. So that is hyperacute type of rejection. That is the meaning of preformed antibodies. Okay, so if before doing the transplant, they do this cross match test to check that whether preformed antibodies are there or not there. And if it is there, you don't do transplant because it will lead to hyperacute rejection, and hyperacute rejection is irreversible. That will cause unnecessary damage of, loss of one kidney. Okay, so that is the meaning of vanishing bile duct will happen in acute. Chronic rejection mein everywhere there will be fibrosis. Vanishing bile duct syndrome can be seen in acute, chronic as well as hyperacute. It can occur in anywhere. Okay, so it can occur in anywhere. That fibrosis part which I am telling you, that is mainly fibrosis occurring in the vessel which is supplying the graft. A patient is having hepatic transplantation, and the priority is based on model for end stage liver disease. They are asking what are the things you see in model for end stage liver disease. The mnemonic is CBI, creatinine, bilirubin, and INR. The maximum score is 40. MELD score more than 15 is indication for transplant. Score more than 15 is indication for transplant in MELD score. Okay, so creatinine, bilirubin, INR, albumin is not a component in MELD score. The last question before we take the break, this is already we have seen. Parathyroid adenoma, the best test to localize is Sestamivi. Option number B. Okay, so we have done 40 questions. The remaining 35 questions are of urology. So that we'll do after the break. Dinas Shaheen was something that I was repeating. If you want me to go again, preformed antibodies to detect, go for cross match test, and if positive then no transplant is done. Okay, preformed antibodies are seen because of prior blood transfusion or prior transplantation. Yes, retransplant means that kidney which you have put already in the patient's body, you have to remove that kidney and you have to put a new fresh kidney. That is the meaning of retransplant. Okay, so Dinaz, if there is positive cross match, means suppose I am the recipient, my kidney is somehow not good and I need transplantation. Now suppose my sister is giving consent. My sister says that okay, she will give me kidney. Okay, so before the kidney will be taken from her, there are lots of tests are done. There is HLA matching is done, ABO blood group matching is done, and this cross match test is done. In the cross match, they are checking that whether in my body already a antibody is present against that blood or against that antigen of my sister. Okay, so that is preformed antibodies. Now these preformed antibodies will be seen. Suppose my sister had given blood to me 2-3 years back because of suppose road traffic accident, and that time she had given blood to me. So 2 years back when she had given blood to me, now in my body already antibodies are there against her antigens. So now if she gives kidney to me, the moment you put the kidney in my body, those preformed antibodies will come and it will destroy that kidney. So that is known as hyperacute rejection. Acute rejection because of T cells and B cells. So in that the rejection will occur in the first 6 months. But that rejection is reversible. Okay, you can increase the immunosuppression dose and you can save that organ. Chronic rejection occurs after 6 months up to years, 5 years, 10 years, 15 years. If any kind of rejection occurs, that is chronic rejection. Okay, there is something else also, like suppose I am the recipient, so my body, the antibodies in my body will fight with the antigen of that organ which is coming from the donor. But suppose ulta occurs, the organ which is coming or you are putting inside me, that has large number of antibodies that will fight against the antigen of recipient. So that is known as graft versus host disease. And graft versus host disease, remember, graft versus host disease, the maximum chances are in small intestine transplant. Okay, remember, in small intestine transplant also the rejection chances are more, and graft versus host disease risk is also more. So that's why small intestine transplant does not have very good result, and people, until unless it is the only option left, they don't go for small intestine transplant. Okay, so Dinaz, is it okay? Okay, so we'll take a break, and after the break we'll see the questions of urology. This is about bladder injury. Okay, so you asked about bladder injury. So so urinary bladder injury. See, the bladder is like this, and the peritoneum comes over it like this. See, suppose this is peritoneum. Okay, so there are two types of injury. One is when it injures at the dome and the urine goes into the peritoneal cavity. So that is intraperitoneal rupture. Another is when the injury occurs in this part and urine comes and collects in this part. So that is extraperitoneal rupture. Okay, extraperitoneal rupture is more common as compared to intraperitoneal rupture. So in this case, when the urine goes into the peritoneal cavity, that will cause peritonitis. Peritonitis means patient will have pain, abdomen, guarding rigidity, okay, tachycardia, hypotension. So in these cases you always have to do surgery. Okay, you need to do a exploratory laparotomy, and you need to wash the peritoneal cavity, so peritoneal lavage, and then you need to repair the bladder with the suture. Repair the urinary bladder, you use absorbable sutures. Extraperitoneal rupture, on the other hand, this is mostly associated with pelvic fracture. So here the urine does not go into the peritoneal cavity, so the patient is not very sick. In these cases, the treatment is mainly put a Foley's catheter, and usually it will heal on its own in 2 to 3 weeks. Okay, so extraperitoneal rupture is not that dangerous, but intraperitoneal rupture mostly we have to operate. Okay, so going back to the question, if we see open repair if extraperitoneal. Extraperitoneal you don't have to do repair. Laparoscopic or open repair if it is intraperitoneal, that is true. Extraperitoneal, no need to do surgery. Indwelling Foley's catheter if intraperitoneal, no. So only correct option here is C. That in intraperitoneal rupture we have to do surgery, be it laparoscopic or open, whatever surgery, but we need to do surgery. And in case of extraperitoneal, just put a Foley's catheter, that is good enough. Next question, a renal cyst with increased number of septa and prominent calcification in a non-enhancing cyst wall does not require exploration but requires timely follow-up, according to Bosniak. Okay, so there is this classification, Bosniak classification of renal cyst. So based on the CT scan, this is the classification of renal cyst. One is, here it is well defined wall, homogeneous, everywhere it will appear same. Thin wall, and on giving contrast it does not enhance. Does not enhance on giving contrast. 2 is, in this there will be 1 or 2 thin septa. Few thin septa, minimal enhancement. Okay, in 2F there is increased number of thin septa, increased number of thin septa, and a non-enhancing solid component. Three is multiloculated. Multiloculated and enhancing septa. And 4 is irregular wall and a enhancing solid. Okay, so this is Bosniak classification of renal cyst. Okay, so if we see risk of cancer, in this it is like 0 to 2%. In this it is 5 to 15%. In this it is 50%. In this more than 90%. So in 3 and 4, usually you go for surgery. Do nephrectomy. In this, follow up. Okay, so in our question it is basically 2F is follow up. So this is 2F, that is follow up. Okay, so we have done just 2 questions. Now comes question number 43, the relationship between the upper and lower pole ureter in complete ureteral duplication. So in duplication, suppose this is bladder. So there is 2 ureters from the same kidney. So suppose this is the lower pole ureter, and the upper pole ureter, it comes, winds around the lower pole ureter and opens distally and caudally to the upper pole ureter. Distal and caudal to lower pole ureter opening. This is known as Weigelt-Mayer's law or Weigelt-Mayer's rule. Okay, see, the first question was bladder injury. So bladder injury can be intraperitoneal or extraperitoneal. Intraperitoneal is less common, mostly because of direct trauma over the bladder. The dome part ruptures and the urine goes into the peritoneal cavity. So because the urine goes into the peritoneal cavity, it will cause peritonitis. Patient will have pain, guarding, rigidity, tachycardia, hypotension. Treatment is you need to do surgery, peritoneal lavage, and repair the bladder using the absorbable suture. In extraperitoneal rupture, the urine collects in the perivesical space. That will not cause any major issue. So that's why in that case, just putting a Foley's catheter is good enough. So that's why option number C is correct in question number 41. This is 42 about the classification of renal cyst. So this is a classification. Okay, you can see that in the recorded version maybe. Okay, 1 is well-defined, homogeneous, thin-walled, does not enhance. 2 is few thin septa, minimal enhancement. So in 1 and 2, the risk of cancer is minimal. So we don't have to do anything as such. In 2F, increased number of thin septa and non-enhancing solid component, the risk of malignancy is this. So we follow up. call the patient every 6 months to 1 year and do the imaging again. 3 is multiloculated enhancing septa, risk of malignancy is 50%, and 4 is irregular wall and enhancing solid component, risk of malignancy is more than 90%. So in these two cases surgery is done, and that is nephrectomy. Duplication, the upper pole ureter opens distal and medial to the lower pole ureter, that is Weygert-Mayer's law, and in this case IVP shows drooping lily appearance. Drooping lily appearance. And IVP finding in this case extraperitoneal rupture. You will see on IVP, not IVP, there is something known as cystogram. Flame sign or Pear sign. Flame sign or Pear sign. Okay, so 43 question, the answer is C. Upper pole orifice being caudal and medial to the lower pole orifice. Okay, adult ischemic priapism. Okay, so priapism basically, priapism is when there is persistent painful erection for more than 4 hours, and this is not because of sexual stimulus. So there are two types, arterial or non-ischemic type. Arterial or non-ischemic type. So in arterial or non-ischemic there is some minor trauma to penis, and if you see the cut section of penis, these are the corpora cavernosa, this is the spongiosa. So the bleeding from the penile artery, it goes into this space, and that will cause partially rigid penis, and mostly this is, you can say, injury to penile artery, central penile artery, partially rigid penis. Treatment is mostly angioembolization. It is not very dangerous. Okay, see, please, I need to finish this class by 9. So if you want me to repeat anything, please, this is my humble request. I know this is the problem for our end, that for some part for like 40 minutes the session was not done because of the whatever network problem and all. So if you find that the speed is more and you want me to repeat something, it is always advisable that you have the recorded version also, so you can see in that recorded version, and even if you don't understand by then, I'll tell you my number, and you can ask me later on any kind of confusion, any kind of thing, you can ask me later. But if I go slow and if I keep on repeating everything again, believe me, we'll not be able to finish it by 9. Another is venous or ischemic type. In venous or ischemic type, suppose this is penis and this is the corpora cavernosa, which has the sinusoids. So there is blockage of the venous return. Okay, blockage of venous return. So there will be accumulation of venous blood. venous blood accumulation, that's why it is known as venous, and in this case there is arterial, so that's why it is known as arterial. Okay, treatment in these cases, first you try to do the aspiration, corporal aspiration, then you inject phenylephrine, and then see if the blood is not going from this, you need to find out some other way through which the blood can go. So people generally make shunt from corpora cavernosa to glans, okay, shunt surgery. From corpora cavernosa to glans, that is known as Winter's shunt. From corpora cavernosa to corpora spongiosa, that is Quackle shunt. From corpora cavernosa to saphenous vein, that is known as Grahak shunt, and corpora cavernosa to you can say the dorsal vein of penis. So basically you are giving another way for that blood to go, that is Berry shunt. Yes, Sakshi. Okay, so these are the shunt surgeries. So we can do the shunt surgeries as an open procedure, but if you want to do it quickly, you can do percutaneous shunt. Okay, one end you put in the corpora cavernosa, other end you put in that other part like glans and all. So that's why in this case the answer is a percutaneous distal penile shunt, because already it is 8 hours duration. He fails to respond to serial aspiration and intracavernosal injection. So now there is so much of time loss, so you want to make the shunt as early as possible, otherwise it can lead to damage, and that's why you are preferring percutaneous distal penile shunt. Saphenous vein Mehak, because see saphenous vein is also going somewhere here only. Okay, so you put the shunt between corpora cavernosa and saphenous vein so that the venous drainage goes from there. Okay, so if you are using saphenous vein, then it is known as Grahak shunt. Grahak shunt. Next question, which of the following statement about penile cancer is false? Cancer penis is not very important for the exam, just a simple thing. Cancer may develop anywhere in the penis, that is true statement. Because of the associated discomfort, patient usually present to the physician within the first month of noting the lesion. This is incorrect. Because of something on the penis, patients are mostly shy and they don't come to the physician unless the lesion becomes too big, and that's why early presentation is not very frequent. Phimosis may obscure the nature of the lesion, that is true. Penetration of the Buck's fascia and tunica albuginea by the tumor permits invasion to vascular corpora, that is also true. Okay, so B is the answer. Rest of the statements are correct. A 42-year-old man has a CT scan after motor vehicle. The most likely diagnosis is, see the left kidney you can see is looking nice, but on the right side you can see the contrast is not going. So this is a renal trauma, and probably the main renal artery is occluded, and that's why cause the problem. Okay, so the main renal artery occlusion is the main problem. Like you said, I will discuss renal trauma. Answer is C, but let's discuss the renal trauma. See, renal trauma, if the patient comes and patient is hemodynamically unstable. Unstable means patient has tachycardia and hypotension. You will do surgery and go for nephrectomy. Okay, you will do surgery, exploratory laparotomy and nephrectomy. Suppose the patient is stable. So in stable patient you go for CCT. CCT will tell you grading, AAST grading, American Association of Surgeons for Trauma grading. Grade 1 is if the patient is having hematuria or a non-expanding subcapsular hematoma. Grade 2 is cortical laceration less than 1 centimeter or a non-expanding perirenal hematoma. Grade 3 is cortical laceration more than 1 centimeter, but it is not reaching up to the collecting system. Not reaching to collecting system. Collecting system means calyces or pelvis, so that the urine leak you will not see in type 3. Type 4, cortical laceration more than 1 centimeter, reaching to collecting system with urinary extravasation. Okay, so there is urine leak in type 4, or if there is renal artery or renal vein contained injury, there is some partial injury to renal artery or renal vein, or if there is expanding hematoma, either subcapsular or perirenal, but if the hematoma is expanding. Type 5 is hilar avulsion or shattered kidney. Okay, so in 1, 2 and 3, non-operative management. You don't have to do surgery in this case. Type 5, nephrectomy. Grade 5, nephrectomy. Grade 4, there are multiple options. You can go for non-operative management. You can go for stenting, put a DJ stent. You can go for angioembolization, or you can go for nephrectomy also. So type 4, there are multiple options, but type 5 straight away you need to go and take out the kidney. Type 1 to 3, non-operative management. Okay, I know I'm going fast, but somehow we are stuck. So just let me know. Okay, if you find that it's too fast, then I can decrease my speed and maybe we can be more slow. So just let me know. Okay, because now nobody is. First investigation for renal trauma. See, Sakshi, it is not about renal trauma. It is the investigation for trauma, because you don't know whether it is renal trauma or liver trauma or spleen trauma. So first investigation for blunt trauma abdomen is fast. Okay, let's see like this. Blunt trauma abdomen, hemodynamically stable, hemodynamically unstable. In unstable, you will go for fast. In stable, first you will go for fast and then you will go for CECT. So CECT is investigation of choice, where fast is investigation of choice. First investigation is fast. Okay, so next question we'll see. There is a female, 3rd trimester of pregnancy, came to the emergency with hypotension, anemia, in shock, and there is a retroperitoneal hemorrhage. CT scan was done 15 months back, which has showed this lesion. Okay, so this is left kidney, which appears fine. The right kidney, the lower pole is almost replaced by this fat or fat containing tumor. So this is very classical of angiomyolipoma, which is made up of blood vessels, muscle and fat. This is the CT appearance. The fat basically shows totally black. And very important, angiomyolipoma, although it is a benign tumor, but yes, there is risk of massive retroperitoneal bleeding, and the chances of retroperitoneal bleeding is more in pregnancy, and that is known as Wunderlich syndrome, when there is severe bleeding in the retroperitoneum. like the patient presented to us with. Okay, so this is angiomyolipoma. Treatment is indication, either the patient is having symptom or it is more than 4 centimeter or female in childbearing age. Okay, the treatment basically done is either you go for, these days angioembolization is more preferred, or you can go for a partial nephrectomy. Partial nephrectomy. Yes, most of you are correct. Next question. There is a patient with hernia, but during the evaluation 3 centimeter testicular mass is noted and primary landing zone or the retroperitoneal metastasis in a left side testicular germ cell tumor. So let's see that testicular tumor here only, although the question is not about the treatment, but still we'll see the testicular tumor. See, suppose this is right kidney and right testis, left kidney and left testis. This is IVC, this is aorta. So there are few lymph nodes which are present around the IVC or in between the IVC and aorta. So the right kidney and the right testis, the lymphatic drainage goes to this paracaval group of lymph nodes, and this is inter means between aortocaval group of lymph nodes. Left testis and left kidney, it goes to the lymph node over and around the aorta. Okay, so this is pre and para aortic lymph nodes. Pre and para aortic lymph nodes. And see, suppose there is something on the right side. So right sided tumors or testicular tumor or the kidney tumor can involve the left sided lymph nodes. Right to left crossover is possible, but left to right crossover is not seen. Okay, means suppose there is right sided kidney tumor. It can involve paracaval, intra-aortocaval, but it can also involve pre and para-aortic lymph nodes. But suppose there is left sided tumor, it will involve pre and para-aortic, it will not involve the right sided intra-aortocaval or the paracaval lymph nodes. Now if I tell you testicular cancer, broadly you can divide this into germ cell tumor and non-germ cell tumor. Germ cell tumor like seminoma and non-seminomatous germ cell tumor like teratoma, mixed tumor, a mixed seminoma or teratoma, yolk sac tumor, embryonal cell carcinoma and choriocarcinoma. Non-germ cell tumor are interstitial cell tumor and others. In others like lymphoma, sarcoma, interstitial like Sertoli cell tumor, Sertoli cell tumor and Leydig cell tumor. Now see, overall most common is this. Yolk sac is most common in less than 3 years. Teratoma is most common in 3 to 13 years. And lymphoma is most common in more than 50 years. Okay, and there are tumor markers like serum LDH, serum HCG. It can increase in both seminoma and non-seminomatous germ cell tumor. But serum alpha fetoprotein is raised only in non-seminomatous germ cell tumor. Okay, it will never raise in a pure seminoma. Now treatment is, see, we don't do any kind of FNAC or biopsy through the scrotum. Transscrotal FNAC or biopsy is contraindicated. Okay, so that's why for investigation as well as for the surgery, you go for high inguinal orchidectomy. High inguinal orchidectomy, that is your biopsy as well as treatment. Okay, so after doing high inguinal orchidectomy, you will send the specimen for histopathology, and then you will come to know that whether it is seminoma or non-seminomatous germ cell tumor. Okay, then there is a staging, TNM staging for testicular cancer. T1 is limited to testis without lymphovascular invasion. T2 is limited to testis with, this is without. This is with lymphovascular invasion or involvement of epididymis or tunica albuginea. T3 is involvement of spermatic cord, and T4 is involvement of scrotum. Now the testis, the lymphatic drainage goes to the these retroperitoneal lymph nodes, those which we have seen, paracaval, interaortic cable, pre and paraortic, those are retroperitoneal lymph nodes. N1 is lymph node less than 2 centimeter in size. N2 is lymph node more than 2 to 5 centimeter in size. And N3 is more than 5 centimeter in size. M0, M1 is no or distant metastasis. Okay, so this is TNM staging. Now for the treatment, the proper staging is required, like stage 1, 2A, 2B, 2C and 3. One is T, T1 to T4, anything N0, M0. Now this is same, this is N1, N2, N3. And 3 is any N, M1. Okay, so this is the staging, the proper staging of testicular cancer. Stage 1 is limited to testis, stage 2 is lymph node involvement, and stage 3 is distant metastasis. Now after doing the high inguinal orchidectomy has already been done. Now the treatment is different for seminoma and non-seminomatous germ cell tumor, because one major difference between these two is, see, testis you have removed, you are not worried about testis, you are worried about the lymph nodes which are there. So in seminoma stage 1, what you will do is, you can either go for surveillance, I'll tell you what are the different options and what is the preferred option, or you can give radiotherapy, or you can give single dose carboplatin. Okay, preferred option is this. There are other options also, but that is preferred. 2A, 2B, either radiotherapy or chemo. Chemotherapy I'll tell you later. These are the drugs BEP3. BEP is bleomycin, etoposide and cisplatin, and 3 means 3 cycles. I'll write it later also. Okay, let me write here only. Bleomycin, etoposide, and P starts for platinum. Cisplatin, carboplatin, and 3 means 3 cycles. 2C and 3 only chemo, that is BEP3. So in 2A and 2B this is preferred, in 1 surveillance is preferred, and 2C and 3 there is only one option, that is chemo. Now non-seminal matter germ cell tumor, they are not radio sensitive, so that's why instead of giving radiation to those lymph nodes, we have to go surgically and remove those lymph nodes. So that is known as retroperitoneal lymph node dissection. So in stage 1 you can go for either surveillance or retroperitoneal lymph node dissection or BEP1, means this is the preferred treatment. 2A or 2B, either retroperitoneal lymph node dissection or BEP3, that is chemo, this is preferred, and 2C and 3 chemo, that is BEP3. Okay, so this is in short the treatment of seminoma and non-seminomatous germ cell tumor. Remember, high inguinal orchidectomy you will do first, and then what you are supposed to do with the lymph nodes, this is as per the staging. As per the staging. Okay. Going back to the question. So this is about the left-sided testicular mass. So this is para-aortic lymph nodes. Strong predictor of acute urinary retention include, see, 20 gram prostate is almost normal size. 18 to 25 gram is the normal size. Qmax more than 15 is also normal. Raised urea is not the predictor for acute urinary retention. A raised IPSS is a predictor. Okay, IPSS, International Prostate Symptom Score. If it is 0 to 7, it means mild lower urinary tract symptom. 8 to 19 is moderate, and 20, or it actually goes from 35, it is severe. So this, if the IPSS, International Prostate Symptom Score, is more than 20, this is an indication for surgery also. This is an indication for surgery. Primary reflux is a congenital anomaly of the uretrovesical junction with a deficiency of, see, one very basic funda you see. Suppose this is ureter. So the moment when the ureter enters into the bladder, it does not open there. Okay, it travels for some distance and it opens at this part of trigone. Okay, it opens here. So this part of the bladder which it travels in the wall of bladder, this part of the ureter which it travels in the wall of the bladder, this is intramural ureter. So longer the intramural ureter, lesser are the chances of reflux. Okay, so suppose this is short and this is long. So if the intramural length of the ureter is short, there are high chances of reflux. Okay, so that's why it is a deficiency of the longitudinal muscle in the intravesical ureter. Intravesical or intramural is the same thing, which results in inadequate valvular mechanism. So that is primary. Secondary reflux is if there is any bladder outlet obstruction that will cause increased pressure, and that increased pressure will cause the urine to go back into the ureter. So that is secondary bladder outlet obstruction, that is secondary reflux. Okay, so primary reflux is because of this short longitudinal muscle which results in inadequate valvular mechanism. What is this anomaly? Can anybody tell me what is this problem? What is the anomaly here? This is a picture of a newborn baby. You can see below the umbilicus the anterior abdominal wall is absent, and you can see the bladder is directly facing the outside environment, and in bladder also the anterior wall of bladder is deficient and there is ureteric opening you can see, and urine may be dribbling out from this. So this anomaly is known as ectopia vesicae or extrophy of bladder. Yes, very good, Sakshi. Extrophy of bladder. So in these cases, the treatment is, these days people are using something known as modified or modern stage repair of extrophy. Yes, very good, Aditi. Say modern stage repair of extrophy. The first thing we will do is at 72 hours after the birth, you will do closure of abdomen and urinary bladder. Now at 12 to 18 months after the birth, you will do the epispadias repair. Okay, epispadias is very frequently associated with ectopia vesicae or extrophy of bladder, and at around 4 to 5 months, no, 4 to 5 years, when the child is good enough to, for the toilet training, you will do the bladder neck repair. Bladder neck repair. Answer for 50 is B. Okay, so they are asking except early closure of the bladder and this, that is the true statement. Early epispadias repair at around 1 year, that is also correct. Conversion of bladder extrophy to complete epispadias, bladder neck reconstruction before the epispadias repair, that is incorrect. Okay, bladder neck repair you will do in the end at around 4 to 5 years when the child knows how to do the toilet training, but when he should understand that if we ask the child to go to the washroom and then do the micturition, so at that time the bladder neck reconstruction should be done. Answer for 46 is C. Okay, so 51 D is the answer. Bladder neck reconstruction will be done later. Modern stage repair of extrophy. Pooja, modern stage repair of extrophy. Modern stage repair. Okay, 52 is a question where a very elderly man, I'll tell you the brief of this question, comes who's having so many comorbid condition, comes with sepsis, heart rate is more and the temperature is high, BP is lower side, the counts are 15,000 and there is a stone lodged at the uretrovesical junction. Antibiotics are given. What is the next best step in the management? So in these cases, there is some obstructive uropathy in an elderly male who comes in sepsis. So thinking about going for surgery is not possible because this patient is not fit enough for surgery. So many comorbid condition. The best thing you can do in these cases is put a nephrostomy tube. Just put a nephrostomy tube. So when you put the tube, all this infection will go out, the obstructive uropathy, and later on you can go and put a, you can remove the stone and take out the stone. (47) the answer is A. Okay, so tell me anything in the stones you want me to discuss. Anything in the stone? Renal stone, anything? I guess most of you are thorough with the stone, the management, the investigation. Any particular thing in the renal stone? If you say, I'll discuss. Why not option D? Because putting a ureteral stent, you will put this stenting when the patient does not have infection. This patient is having infection. Urine analysis reveals, see, at RBCs, WBCs, and also the patient is having peripherally, you can see the band cells, and also the patient is having sepsis. So in this case, you don't do this endourological procedure in case of active infection. So that's why you will not do this. Okay, let me briefly tell you about the stones. I'm not going into types of stone, just the investigation. Investigation of choice is NCCT KUB. NCCT KUB. If the comorbidities were not there and the patient was stable and the infection was not there, then D would have been the option. You do URS and take out the stone. Okay, and in pregnancy it will be MRI. Okay, now treatment of kidney stones. Less than 0.5 centimeter, there are chances of spontaneous passage. It will pass on its own. Less than 1 centimeter means 0.5 to 1 centimeter, ESWL is the preferred treatment. More than 2 centimeter, PCNL is the preferred treatment. 1 to 2 centimeter, either ESWL or retrograde intrarenal surgery, RIRS. Okay, ureteric stone. Ureteric stone, less than 5 mm, spontaneous passage. 5 to 10 mm, either ESWL or medical expulsive therapy. Medical expulsive therapy will give drugs which will cause dilatation of the ureteric muscle and it will allow the stone to pass, like the drugs which we give, tamsulosin, calcium channel blockers, PDE5 inhibitors. Okay, and more than 10 mm, ureteroscopic removal of stone. Okay, so this is the management of kidney stone and the ureteric stone size wise. Now in pregnancy, both ESWL and PCNL are contraindicated. The only option left in the pregnancy is URS or RIRS. URS or RIRS. Okay, so this is the management of renal stones size wise. Rest of the things I hope you know the different types of stones and which is radio opaque, which is radiolucent. Okay, so I'm not going into that, which is formed in the acidic urine, which is formed in the alkaline urine. URS is ureteroscopic removal of stone. Okay, Mehak, ureteroscopic removal of stone, where you will go into the bladder and through the bladder you'll find the ureteric opening and put a small catheter that is known as Dormia basket and catch hold the stone and take it out. Okay, so nephrostomy tube is the best answer in this case. Infant is found to have undescended testis. During his 6-month checkup, the left testis remains undescended. What can be done to decrease the patient risk of developing cancer later to match that boy without cryptorchidism? Okay, so what is the answer in 53? See, undescended testis. No treatment is done. The risk of cancer is 40 times high. If you do the treatment, still there is risk of cancer that is 4 to 5 times high. So it can never be same as that of a boy without cryptorchidism. Without cryptorchidism. What is R1? I don't know. I did not write R1 anywhere. RS I had written. If the patient is stable in that case, heart rate, urinalysis is uretrovesical junction stone is lower ureteric stone. Okay, so in case of lower ureteric stone, URS is a better treatment option. Okay, URS is a better treatment option. ESWL anyways you never do if the patient is in active infection. Diagnosis in 52 is uretrovesical means ureteric stone. Okay, so risk cannot be decreased to that of a boy without cryptorchidism. Undescended testis, the ideal timing of surgery is 6 months. Okay, so you can wait up to 6 months. If it has not come down by 6 months, it will not come down. Okay, in the books it was written previously that you have to do surgery between 6 months to 1 year, but now the guidelines are clear, you have to do at 6 months. Okay, don't wait till 1 year. At 6 months, do the surgery. Next question, briefly I'll tell you, 32-year-old man and after the newly married, and he comes with this picture and he says that he fell and that's why this thing is there. The temperature is okay, blood pressure is okay, pulse is slightly high. So this is very typical of fracture penis, which occurs mostly at the time of sexual intercourse, and suddenly the rigid penis will become flaccid. This is also known as eggplant deformity. Eggplant deformity. The basic injury is in the tunica albuginea. Tunica albuginea is the layers of the corpora cavernosa. Okay, suppose this is corpora cavernosa, where there is sinusoids or the erectile part. Tunica albuginea is the covering of this. So when there is injury to tunica albuginea, the blood comes and collects around the penis. That is fracture penis. Urethra is usually spared. Urethra does not involve, and sooner or later, I mean as soon as possible, you need to go for surgical repair. There is no other treatment apart from surgical repair. Okay, so not a very dangerous thing, but yes, if delay in the treatment is done, then it can lead to some kind of permanent damage in the penis. Okay, so this is typical picture, fracture penis, and usually the patient, they hide the history, especially this like younger patient, newly married, so they are shy or whatever, so they don't give the proper history, they say something else, some kind of other trauma. Okay, so now you are asking about prostate cancer, so let's discuss the prostate cancer in this, but first we'll see this question answer and then we'll talk about the prostate cancer. The question was, a patient, he requested for prostate testing because his father had this. So you did a distal rectal examination which shows normal prostate. PSA was then done because the patient asked to get the PSA also, and the PSA was slightly high. What is the which is the next step? Okay, so see, if you do a distal rectal examination and after that you do the PSA, so PSA will come high even in normal cases. Okay, so you have to repeat PSA test. PSA is not done after doing the distal rectal examination because that can give a false high PSA. So you will repeat the PSA test in this. Now we'll discuss prostate cancer, some important things about prostate cancer. Prostate cancer is a type of adenocarcinoma. Okay, from the peripheral zone or the posterior lobe it arises. Investigation of choice. For diagnosis, the investigation of choice is transrectal ultrasound guided biopsy, and for screening it is distal rectal examination and serum PSA. That is for screening, but for making the definitive diagnosis, stress guided biopsy. And see, anatomically you say that in prostate there are 5 lobes and all, but clinically we just say that there are 2 lobes, right and left. So from each lobe you take 6 biopsies. Okay, 6 biopsy from each lobe. So total 12 biopsies you will take if you are taking biopsy for prostate cancer. Okay, multi-parametric MRI is used for to see the spread and all, and sometimes prostate specific membrane antigen PET is also done. Not in all cases, but yes, in few equivocal type of cases you can go for this. When you are not sure it is cancer or not cancer, you can go for this. Otherwise, this is to know the spread. Okay, so in this case, staging is important. See, T1A and T1B is post TURP. You have done transurethral resection of prostate for BPH. So when you do transurethral resection for prostate, you will cut multiple small pieces. So when you send those pieces for the biopsy report comes and it says it is cancer. Okay, so in that, if there is less than 5% of, okay, you can say tumor occupying less than 5% of specimen, tumor occupying less than 5% of specimen. T1B is tumor occupying more than 5% of specimen. T1C is that there is no nodule but biopsy was done because of increased PSA and that shows cancer. Okay, there is no nodule palpable. Now first, that is what I am saying, Shrey. First you will take PSA. First you take PSA sample and then you can do whatever, you put your finger and you can keep on moving. That does not happen. Okay, so in DRE and PSA, first you take PSA and then do DRE. T2 is palpable nodule in the prostate. T2A is this nodule involving half of one lobe. B is involving more than half of one lobe. C is involving both lobes. T3A is if the tumor goes beyond capsule of prostate, and B is if it involves seminal vesicle, and T4 is when it goes to the adjacent organ. Like posteriorly it involves rectum, anteriorly it involves maybe bladder and all, so then it is T4. Okay, now a very important thing in the management of prostate cancer is a slowly growing cancer. So age of the patient, or you can say life expectancy of the patient, is also very important factor in deciding the treatment. Okay, so now T1 and T2A. If the life expectancy is less than 10 years, means the age is more than 70 years, in these cases you will do wait and watch. Wait and watch means you will not do anything. You let the patient live. Life expectancy more than 10 years means age less than 70 years. In these cases you can go for, I'll tell you what is these later, active surveillance, or you can go for surgery, radical prostatectomy, or you can give radiotherapy. So all three are options. Depending on the patient condition, we can decide among these three which one is to be preferred. For T2B and T2C, more than 10-year life expectancy, either radical prostatectomy. Okay, let's do like this. Life expectancy less than 10 year, same, wait and watch. And life expectancy more than 10 year, you will not do active surveillance, you will do radical prostatectomy or radiotherapy, any of these. T3A, radiotherapy or radical prostatectomy or hormonal therapy, any of these, hormonal therapy. T3B and T4, radiotherapy plus hormonal therapy. Okay, so this is stage wise treatment of prostate cancer. Now I'll tell you what is active surveillance. You will do PSA and DRE every 6 months and biopsy yearly. In wait and watch, you don't do anything. You just tell the patient that okay, it is cancer, but you live with the cancer, not a problem. Radical prostatectomy will remove the prostate, seminal vesicle, vas and pelvic lymph nodes. Radiotherapy will give 74 to 80 gray. Mostly people use these days brachytherapy, where you will put the small seeds of this radioisotope like iodine 125 or palladium 103 inside the prostate parenchyma. Hormonal therapy like enzalutamide, abiraterone, so these will decrease the testosterone level basically. Degarelix is LHRH antagonist. Bosserelin, goserelin are LHRH agonist. Or orchidectomy can also be done. Okay, so this is in short the treatment of prostate cancer, the investigations, staging, stage-wise treatment. Okay, and in the book, the type of Gleason staging which you read, that type of Gleason staging is not used these days. In the Gleason, there is new grading system. So I'll tell you the thing which is done practically these days. Previously the grade was different, stage was different. There is grade 1 to 5 and then another grade 1 to 5. You add this and then it will become stage. Nowadays there is modified, or you can say new grading system, Gleason. Here grade 1. Grade 1 we'll say is score is 3 plus 3, that is 6. So in this only discrete well formed gland. Gleason 2, that is 3 plus 4, 7. Predominantly well formed gland and lesser component of poorly formed gland. Gleason 3. Okay, let me write it like this. Gleason 1, 2, 3. 3 is 4 plus 3, that is also 7. Okay, predominantly poorly formed glands and lesser component of well formed glands. With grade 4, the score is 4 plus 4, that is 8. Only poorly formed glands. And 5 is either score is 9 or 10, that is lacks gland formation. Higher the gland, higher the grade, higher the score. This is score 6, 7, 7, 8, 9, 10. This is score. Okay, this is score. And 1, 2, 3, 4, 5 is grade. So that is Gleason grade or Gleason score, although it is mainly a pathological thing, but still let's finish the prostate cancer with this. Okay, 56. This is very simple. This is paraphimosis. Okay, we will not discuss anything. This is paraphimosis. I hope all of you know. This is bag of worms. So this is varicocele. Now if you see, varicocele is mostly seen in younger patients like 10 to 25 years. Here the patient is 78-year-old. And also there is hematuria, there is flank pain, and there is mass also. So very typically this is a case of RCC presenting as varicocele. Okay, so this is basically renal cell carcinoma which is presenting as varicocele. Left-sided renal cell carcinoma can present as varicocele because the tumor thrombus will block the left renal vein and the pressure will be gone into the left, this gonadal vein or the testicular vein, and that's why varicocele will be seen. Okay, yes. Any question if you want me to discuss like more, you let me know. Which of the following statement regarding hypospadias is correct? Okay, you were asking about hypospadias, the step C. In hypospadias, suppose this is the urethra. Instead of going to the meatus, it opens somewhere proximally. And the urine comes out. Distal to that part, the penis will deviate downward. Distal to the abnormal opening, the penis deviates downward, so that is known as chordae. So it is moving on the ventral side, so we call it as ventral chordae. And there will be some extra prepuce there, so that is known as hooded prepuce. Hooded prepuce. So now when we do the surgery, testicular, what Faizan, testicular cancer, so we have seen. What exactly in testicular you are asking? So the first thing we need to do is we want to make the penis straight. So that is orthoplasty first. So you will make the penis straight, but opening is still there. So first orthoplasty. Then you will do the urethroplasty. Urethroplasty means now you will remove the urethra from here and you will make a new urethra which is going up to this part. And then you need to give shape to the glans of the penis, so that is granuloplasty. Okay, now you will give some shape to the glans, that is granuloplasty. And after that there is meatal stenosis, you will do meatal dilatation. So this was the step you are asking for the treatment of hypospadias: orthoplasty, urethroplasty, granuloplasty and meatal dilatation. Testicular cancer does not present like varicocele. Okay, testicular cancer will present as a testicular mass, or it can present as an abdominal lump because of the involvement of the lymph nodes. Okay, it cannot present as testicular cancer. Okay, this involvement is not seen in testicular cancer. Testicular cancer does not present as varicocele. Okay, so which of the following statement regarding hypo? It is associated with chordae, that is true. It is associated with undescended testis. Undescended testis is seen in 10% of cases. It is a rare fusion defect of not posterior, anterior male urethra. The most common location is not penoscrotal, it is anterior hypospadias, that is in the glans or in the corona. Okay, so only option number A is correct. Only option number A is correct in 58. Initial management of a patient who has a flaccid neurogenic bladder. See this, just one more thing we'll see. See, suppose this is brain and this is spinal cord. So this is pons. It has the micturition center. And suppose this is T11, this is L2, and this is S2, S3, S4. So if there is any injury occurs in this part, that will lead to upper motor neuron bladder. Upper motor neuron bladder may the problem is the bladder will contract too frequently. Okay, too frequent contraction and the sphincter does not relax and it can lead to vesico-ureteric reflux. Upper motor neuron bladder. Patient can have urge incontinence. The treatment is anticholinergics. If there is any injury in this part, that will lead to lower motor neuron bladder, no sensory and motor supply to bladder. Okay, so this is, what is the question? Flaccid neurogenic bladder, no sensory or motor supply. So this can lead to overflow incontinence. And the treatment is clean intermittent self-catheterization. Okay, so a patient has to do self-catheterization. Clean intermittent self-catheterization. The answer for 59 is self-catheterization. Depending on which side is the injury, there can be upper motor neuron bladder or lower motor neuron bladder. Self-catheterization. Okay, next question. Question number 60 is about torsion. Which of the following statement regarding the patient diagnosis is true? There is strong likelihood that the father and brother, that is not correct. Operation should not be delayed. You should do surgery within 6 hours if you want to save the testis. Can be salvaged if surgery is performed within 24 hours. That is incorrect. It can be salvaged if the surgery is performed within 6 hours. If torsion is found, both testes should undergo orchidopexy. So that is, I'm sure all of you know this, that when you are doing orchidopexy, you have to do on the affected side as well as on the non-affected side, because the same problem there can cause the torsion in the future. How you determine lower motor neuron lesion? Depending on the patient's symptoms. Okay, and also you can get the MRI done, but mostly the patient's symptoms will tell you that whether it is upper motor neuron or lower motor neuron injury. Okay, genitourinary tuberculosis in a male patient is suggested by which of the following findings? See, 20 minutes and almost 15 question, Aditi. So sorry, I'll give you my number. Okay, in that you can ask me, and maybe on one day I can take a class on the neurogenic bladder. That day I'll explain, but I need to finish the paper. There is some restriction. I am taking a class from studio. Studio has to close at 9. So, okay, you can ask me. Okay, I'll explain you, or maybe I'll make a short video and that I'll post so that you understand the neurogenic bladder part. Microscopic hematuria is the answer. Okay, there is sterile pyuria. What are the features you will see in genitourinary sterile pyuria? Okay, putty kidney or cement kidney golf hole ureter, thimble bladder. Pneumaturia is usually you will see in colovesical fistula, when there is fistula between the colon and the bladder. Okay. '62. Which of the following statement regarding BPH is true? The fibrostromal proliferation of BPH occurs mainly in the outer portion. This is incorrect. Mainly it occurs in the periurethral part of the prostate, so that it will cause urethral obstruction. Assuming avoiding volume greater than 100 ml, peak urine flow of more than 30 or less is good evidence of outflow obstruction. If this flow is less than 10 ml per second, then it is good evidence of outflow obstruction, so this is incorrect. Suprapubic prostatectomy for BPH involves enucleation of the entire prostate and eliminates the risk. When you are doing surgery for BPH, you don't remove the entire prostate, and that's why the future risk of cancer remains there. In question 60, option is D, Faizan. I don't know. In 61, pneumaturia is a colovesical fistula, a fistula between colon and the bladder. Then there is pneumaturia is seen. Pneumaturia is when there is air comes from the urine. Indication for surgery include acute retention and recurrent UTI. That is the true statement. That is true statement. This is about the urethral injury. So, like I promised, few things I need to discuss. So that I'll discuss urethral injury. Okay, see, suppose this is how the urethra goes. This is prostate. So this is prostatic urethra. This is membranous. There goes the pelvic diaphragm, bulbar urethra, penile. So penile is protected by the penis. Prostatic is protected by prostate. So injury can occur in bulbar or membranous urethra. Okay, bulbar and membranous. Bulbar is more common, membranous is not that common. Bulbar is because of direct injury to perineum. Direct injury to perineum, like that is known as fall stride injury or straddle injury. Membranous is because of road traffic accident with pelvic fracture. Okay, in bulbar there is hematoma in perineum. Membranous, there is hematoma in perivesical area. Perivesical area. In both the cases, there will be inability to pass urine and blood at tip of meatus. One important thing which you will see in the membranous is high lying prostate. The prostate will go higher up. In both the cases, treatment is do not put Foley's catheter. Don't put Foley's catheter. First you will do suprapubic catheterization. Then you will do retrograde ureterogram to see the site of injury and do a delayed urethral repair or urethroplasty, usually after 8 weeks or 12 weeks when the edema settles, inflammation settles, then we do this. Yes, that is known as Vermeulen sign, Shrey. Okay, so do not put Foley's catheter, do a SPC, get a retrograde ureterogram done and do a delayed urethral repair. Okay, so D is the answer. Okay, so this is about there is a bladder frank hematuria, passage of clot. So when the clot comes from the bladder, mostly we see in an elderly patient, it is most likely because of bladder cancer. So those clots can go and it can block the Foley's catheter. So that's why we put a three-way Foley's catheter. In three-way Foley's catheter, one end through which the urine will come out, another end is for inflation or deflation of that balloon, and the third end is through which the continuous irrigation will go, so that clot does not obstruct the lumen of the catheter. Three-way catheter. Okay, so next question, hesitancy, poor stream, and his PSA is 30. Most appropriate next step. This looks like a carcinoma prostate. The most appropriate next step is prostatic biopsy. Okay, if you are suspecting, prostatic biopsy is the best next thing you can do. Okay, this question is about RCC. So let's discuss one or two important things about RCC. RCC. Question number 64. Why not? Answer is D. Because the patient is already having who is admitted with frank hematuria with passage of clots. He is now complaining of lower abdominal pain and inability to pass urine. The patient does not have any trauma. Okay, so it is not that every time the patient comes with inability to pass urine, you will put a suprapubic catheter. Suprapubic catheter you will do if you cannot go through the normal urethral route, if you are suspecting a urethral injury. In this case, there is no history of any urethral injury, so why would you put a suprapubic catheter? This is a clot which is obstructed, so that's why you put a Foley's catheter. Okay, Faizan. RCC, two important things. Cause, C, smoking, obesity. Okay, and if you see other things like polycystic kidney disease also increases risk a bit, but mainly it is the hereditary factors. Hereditary factors. So what are the syndromes associated? Vermeulen sign is high lying prostate. Okay, when the prostate is on rectal examination goes high, that is Vermeulen sign. Clear cell RCC type is associated with VHL syndrome, where the gene is VHL. BAP1 mutant disease, where the gene is BAP1, and SDH associated kidney cancer, where the gene is SDH, B, C, and D. Papillary RCC, papillary type. Here the syndromes associated hereditary leiomyoma and RCC syndrome. Gene is FH, or hereditary papillary RCC syndrome. Gene is MET. And multiple tumor types like Birt-Hogg Dupe syndrome. This question is about Birt-Hogg Dupe syndrome, where the patient is also having pneumothorax. Okay, and because of this pneumothorax, because of this lung cyst, patients are having pneumothorax. Okay, the patient will have cyst in the lung, and that's why the patient has history of this pneumothorax. Tuberous sclerosis, TSC, and Cowden syndrome, that is PTEN. So remember these syndromes and genes associated with RCC. RCC, the TNM is not very important. If you see the treatment part, You can go for partial nephrectomy or radical nephrectomy. In radical nephrectomy, you will remove the kidney, ureter, but in partial nephrectomy, you will remove only a part of the kidney. When to go for partial nephrectomy? Less than 4 centimeter, bilateral RCC, single functioning kidney, and VHL syndrome. So in these cases, you go for a partial nephrectomy. In rest other cases, you go for a radical nephrectomy. Okay, so the question in this is, answer is FLCN because this is Birt-Hogg-Dube syndrome. Birt-Hogg-Dube syndrome. Next question is about testicular cancer. Okay, testicular cancer, this is a mixed germ cell tumor, so you consider it as non-seminomatous germ cell tumor. The patient is having a testicular mass, no lymph node or visceral metastasis, so this is stage 1. The question is, which of the following would not be a reasonable next step? So stage 1, surveillance we do, radiation to the retroperitoneal lymph node we don't do, BEP 1 cycle we do, nerve sparing retroperitoneal lymph node dissection, so B is the answer. We don't do radiation in non-seminomatous germ cell tumor, rest all are the options which can be done in that. Okay, this is the last cancer we'll see, that is about bladder cancer. Answer here is C, repeat staging with TURBT. So just bladder cancer, TIS is carcinoma in situ, TA is non-invasive bladder tumor, T1 is involvement of lamina propria, that is mucosa, T2 is detrusor muscle involvement, T3 is perivesical fat. Consider just 4 centimeter now, although up to 7 centimeter also people they go, but preferred is up to 4 centimeter. Up to 7 centimeter also most of the people they can do. 4 is adjacent organ. So TIS, TA and T1 is non-invasive bladder tumor and T2 to T4 is invasive. So in invasive cases, the treatment is first you give neoadjuvant chemo and then go for radical cystectomy. For non-invasive cases, you can go for transurethral resection of bladder tumor. Okay, you don't have to remove the whole bladder, you can go for TURBT. After TURBT, if it is T1, no not T1, if it is TA and less than 3 centimeter and low grade. So TA less than 3 centimeter and low grade, you can go for single instillation of intravesical chemo. So in this you will give mitomycin C. But if it is TIS, T1 or TA which is more than 3 centimeter or high grade, after TURBT you give immunotherapy, that is intravesical BCG, and this you have to give every 6 weeks for 1 to 3 years. So when you are doing TURBT, when you are resecting the bladder tumor, there has to be muscle in the specimen. If the muscle does not come, it means you have not done adequate surgery. So in this question, that point was given, that because muscle was not in the specimen, so what you will do? You will do TURBT. If muscle is not seen in specimen, then you will go for re-TURBT. Okay, this is a question. Next question is about Crohn's disease. Okay, so in this there is basically ileal resection, and because of ileal resection there is fat malabsorption, and because of fat malabsorption there is increased fat in GI lumen, and it will bind with calcium, and the calcium does not bind with the you can say oxalate, and oxalate gets absorbed, and that will lead to stone formation. So increased absorption of oxalate will lead to stone formation. That is that question actually. You can read the after the answer what is written. Okay, the description, you will understand this. This is a congenital hydrocele. So congenital hydrocele, up to 2 years you can wait and watch. In this question, the male infant, so you will reassure. Up to 2 years, wait and watch. Beyond 2 years, herniatomy. Hernia you repair as early as possible, but in hydrocele you can wait up to 2 years. Okay, next question is about the electrolyte abnormality when you use a bladder diversion. So let's see, in stomach, if you use stomach, you will find hypochloremic, hypokalemic, metabolic alkalosis. This is something which you need to remember because they ask in the exam. Jejunum, hyperkalemia, hyponatremia, hypochloremia. Ileum, hypokalemia, hyperchloremia, and metabolic acidosis. In jejunum, it can lead to metabolic acidosis or metabolic alkalosis, anything it can cause. And colon and ileum is same, basically hypokalemia, hypochloremia, metabolic acidosis. So this thing you remember, colon and ileum is almost same. Stomach you can remember if you remember IHPS, infantile hypertrophic pyloric stenosis, the same kind, hypochloremic, hypokalemic, metabolic alkalosis. Sodium you will see only in jejunum type, in rest all you will not see sodium. Okay, so this answer is A. Okay, the next question is about there is some ureteral injury and the patient is this is prostate is normal, no blood on insertion, gross hematuria, CT, large amount of free fluid in the peritoneum. So this is bladder dome injury. Okay, this we have already seen, bladder dome injury. Next question, in this question there is some ureteral injury, and because of ureteral injury the too serious to allow time for definitive repair. So in these cases, in 73, you ligate the injured ureter and do a ipsilateral nephrostomy. Later on you can do the definitive repair, but the proper treatment in this I'll tell you. Okay, this is the last thing and then we'll end. It is beyond 9. So suppose there is injury with no loss of length. In that case you will do end-to-end repair putting a DJ stent. Okay, end-to-end repair over DJ stent. Yes, important TNM, I'll tell you. Okay, if there is no loss of length. Suppose it is like this, little loss of length. Then in these cases, the treatment option are you mobilize the kidney, bring the kidney towards the bladder, or you take the bladder towards the ureter, that is psoas hitch, or you use a flap from the bladder wall to do the reconstruction, that is Boari flap. And if there is significant loss of length, then you can join these with this. So this is known as ureterolithotomy, ureterostomy, or you can put appendix. You can put an appendix and do the reconstruction, appendix or ileum as interposition. (72) The answer is C. Mehak, C. It is the dome of the bladder which has caused peritonitis. 73, the answer is A. This is in general the treatment of ureteral injuries. This is a stone, and in the pelvis this big stone is because of triple phosphate. Option number D. Pelvis stone is basically big stone is triple phosphate. This is about the mixed seminoma and embryonal, means it is a mixed tumor. Mixed tumor are treated as non-seminomatous germ cell tumor. Okay, so this is a mass which is 2.8 into 1.4, and there is a N2 lymph node and whatever T1 N2 kind of tumor. So N2 means this is stage 2B. Non-seminomatous 2B, you will do bilateral nerve sparing retroperitoneal lymph node dissection. Okay, the important TNM for in urology: prostate, testis, general, breast, oral cancer, GIT, colorectal, esophagus. Okay, in hepatobiliary, liver, gallbladder, pancreas, you don't need any TNM staging as such. Okay, I am really I apologize for the the second half of the discussion because of the something happened during the break, that there was some breakdown in the system, and that's why I had to rush. So see, you can tag me the questions. 72 is, see, there is upar ki, there is some kahani. His abdomen appears distended, mildly tender. Pelvis is stable, means there is no fracture. On rectal examination, prostate feels normal, no fracture. No blood at the meatus, means no urethral injury. On insertion of Foley's catheter, there is blood comes out. CT shows IV contrast and large amount of free fluid and contrast in the peritoneum. So what do you think could be the injury? Okay, there is very clear cut, it is the bladder dome. It is the bladder dome. Okay, you can tag me on our DAMS exclusive club, any kind of question, not just this part of the TND, anything in the surgery, you can tag me, and most of the time I do reply, and I seriously apologize for this the part, and I don't know if you have access to the your TND. This same TND was discussed few months back also. So if somehow you get the access to that part, maybe you can go through the video in that class. We had time, so we had discussed the things. Okay, so if possible, just find out the same paper was discussed few months back, and that if you get the access, that will be better. Okay, thank you very much, and any kind of doubts are most welcome. 73 is, see 73, the treatment is this basically. Okay, in your exam you need to know this treatment. That question was a little bit higher funda, that there was injury but the patient condition is felt to be too serious to allow time for definitive repair. All these were definitive repair. Patient does not have that much time for definitive repair. So what can you do is you ligate the injured ureter. Okay, suppose this is where the injury has occurred. So you ligate this and put a tube and close the patient, because the patient does not have time. So ligation of the injured ureter and ipsilateral nephrostomy. Okay, so thank you very much, and